Three, two, one. We are live now, sir.
Good evening, everybody. Myself, Dr. Vishal Dave, medical advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for the Synergy Club 9 webinar on the topic hyperglycemia in pregnancy in association with Infertility and Reproductive Endocrinology Committee of Association of Obstetricians and Gynecologists of Delhi. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
I would like to introduce the convener of this webinar, Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal Obstetrics and Gynecological Society. She is founder-president of ISOAP chapter of Bhopal. She is national executive member of ISAR, as well as she is the convener of ISAR Perfection Series and Foxy Symbiosis Series. Over to Dr. Monica Singh.
Thank you, Dr. Vishal, from Intas Pharma for sponsoring our show since a long time. And at the outset, I would like to thank Dr. Picky Saxena ma'am from the Infertility and Reproductive Endocrinology Committee of the Association of Obstetricians and Gynecologists of Delhi for giving us this opportunity to collaborate with them and to present this very, very important, significant webinar on hyperglycemia in pregnancy. And it seems to me we are in the continuation of the webinar we did with MDIP Committee of Foxy.
Yes.
Last, where we had the opportunity of listening to deliberations of Seshaya sir on primordial prevention of diabetes. So I think in the morning when I talked to Dr. Seshaya sir, he said that he has, taken the talk forward, and we are so excited to listen to him today. And but we have to, fulfill our formalities. So I would like to now invite chief guests of our program, Dr. Seshaya sir and Dr. Kavita Singh ma'am.
Thank you.
Ma'am, would Picky Saxena ma'am, would you like to do the honors, or should I?
You can continue, Dr. Monica.
Okay. So I am honored to invite sir, just 2-3 lines for our viewers. Professor V. Seshaya is Padma Shri, an honorary distinguished professor of the Tamil Nadu Dr. MGR Medical University for Life in Chennai. Sir was established the first Department of Diabetology in India at Madras Medical College in 1978, and Diabetes in Pregnancy Division in the Institute of Obs and Gynae Government Maternity Hospital, Egmore in 1980. He is the patron of the Diabetes in Pregnancy Study Group of India, DIPSI. Sir has received Army decorations, Samar Seva Star in 1965, and Sanya Seva Medal with Clasp Himalayas. He is the recipient of the very prestigious Dr. B.C. Roy National Award in 1988 for the development of diabetology as a specialty in the country. Sir is the awardee of the Lifetime Achievement Award by International Diabetes Federation of 2017 and the first Indian to receive this award. Sir, we all know, is Padma Shri awardee in medicine by President of India in 2022. Sir, we are so honored to have you in our midst, and we would like to have a few words of blessings from you, sir.
Oh, thank you. Thank you very much, Dr. Monica Singh. And Nandini Singh and Picky Saxena, I came because here, Dr. Picky Saxena told me that I must talk to this conference here. I was very happy to meet you all. And I met you already somewhere in the conference, but Picky is known to me so many years. I am happy to come over here, share my opinion and my work so far, 40 years, almost 45 years, from 1980 and 78, we started that department. Then, of course, in India, first time we started the diabetes and pregnancy service. So anyway, I'm old, still I can work, no problem. I would like to share my views, and every time I'm coming with certain new ideas, I'll share with you. Only thing I was very happy with you people. Hyperglycemia in pregnancy is first fantastic title you have given. Yes, I am fed up with calling GDM because GDM Why I'm telling GDM, it's good. But you know, a young lady who's pregnant in the family, and if you tell her you got a GDM, she'll be shocked. Not only she, her relatives, mother, everybody will get shocked. So you should not use the word diabetes at all. So what you have done now will be good. I don't know how we are going to stress this, what do you call name, the hyperglycemia pregnancy. I think you must spread in your Foxy people, or this is why you must start working on this. Only when after the first time is over, probably you can tell GDM. When first time is itself, when somebody blood sugar is a little high, you just say hyperglycemia. Why should we call it a GDM? So I am so happy when title this conference today is given is hyperglycemia pregnancy. I am happy for that. I am congratulate you for introducing this particular topic, which I have been thinking for so many. I thought number of years, but again this goes back to GDM. Now I think at least this should be the seed for the future. You insist on hyperglycemia pregnancy, HIP. So that is what my message now here. That when I start talking, when time comes, 4:30, when other people are there, I'll start. Thank you.
Thank you. Sir. Thank you. And hyperglycemia and pregnancy, I think it was a word coined by MDIP committee. Dr. Manoj is there. This term I came across first in the MDIP committee webinar, the signature webinar series, which was started by none other than Dr. Manoj Chilani, who is amongst us. Congratulations, Manoj. And he did a brilliant series of webinars, I think 6 episodes, in which we dealt with hyperglycemia and pregnancy at length. And of course, Picky Saxena ma'am, because then we stuck to this term and it appears to be all good because it really, removes that stigma from labeling a pregnant woman as diabetic. Thank you, sir.
Historically, this hyperglycemia pregnancy was introduced by Louise Jovanovic from States. She has come to Chennai. I know her many times, met her. Then another fellow I forgot in UK. We decided to have hyperglycemia, but after that we are not able to proceed further. Now your group, now you should start on that. So
Yeah,
hyperglycemia pregnancy is the ideal thing to start.
yes, sir, because these are stalwarts of Foxy with us. Dr. Manoj is chairperson, MDIP committee. Picky ma'am is the coordinator. I, of course, am working with multiple committees. Dr. Bhav Tarni is there. Anjali madam is there from Bhopal. Sumitra madam is there from Indore. Alka Pandey madam is here. So we can really, put that message across OBGY specialists of India that do not use the term GDM till the patient is advanced into her pregnancy.
Yes, good.
Yeah, start with a milder term like hypoglycemia and pregnancy, which becomes more manageable and more digestible by the patient. Thank you,
And
sir.
is that hyperglycemia will encompass all the minor degree of hyperglycemia, severe degree, and all, which Tipsy 2023 and Dr. Shaya has now framed. So I think hyperglycemia, sir, it was introduced by you only, and that is why we took this up in the Medical Disorders Committee of Dr. Chilani.
Thank you, Picky ma'am, for those inputs. And now I take deep pleasure in introducing our chief guest for today, Dr. Kavita N. Singh ma'am, who is Dean of our college, Gandhi Medical College, Bhopal. Madam is a very, very dynamic academician who still, from the Dean office, we hear that she regularly goes to the Department of OBGY. She operates on a patient early in the morning and follows up that case beautifully. So, ma'am, kudos to you for your energy and dynamism. You have taken the college to another level. Madam has been professor and head of OBGY at NSCB Medical College, Jabalpur, IACA Fellow of Gynecology Oncology at Roswell Park Cancer Institute, Buffalo, New York, and Tata Memorial Hospital.
I think Monica, you can leave all this because if Professor Shasha is there, we should save time and we are all eager to listen to him. So my regards to Professor Shashaya. Namaskar.
I just wanted
Good
to
evening.
mention that Madam is heading the MP Gynec societies. All the Madhya Pradesh OBGY societies are under the umbrella of AMPOGS. Madam is the president of AMPOGS at present. and she has taken also AMPOX to further heights with her programs and her vision and her, constant outlook. So, Madam, we would like to have a few words from you, please.
Yeah. Thank you, Monica. Thank you so much. And God bless all of you, those who are younger to me, and my regards to sir. And I am really honored to be part of this very, very, very prestigious oration of Professor Sheshaya, that is on HIP. I congratulate Picky and you, and I am so happy to see all my friends in the screen. And my best wishes to everyone. I am looking forward to listen to sir. Thank you so much. Thank you.
Thank you so
Thank
much.
you, ma'am. It's a pleasure to have you with us and to have your blessings. Thank you so much.
Thank you, ma'am. Thank you, ma'am. And I think we got a message from Dr. Sharda Jain ma'am in the morning that she might not be able to join. She's probably traveling for some family this thing. So we introduce our guest of honor for today, Dr. Anjali Kanhare ma'am. Dr. Sharda Jain might be joining. Purva, can you put a call or message to Sharda ma'am? Just,
Yes, ma'am. I have already done. Yes.
Thank you. Thank you.
Ma'am is not responding. I tried as well.
Ma'am is not responding.
Okay,
Yes.
ma'am. So, welcome Dr. Anjali Kanhare as the guest of honor for today evening, this webinar on hyperglycemia in pregnancy. Madam is one of the very, very senior gynecologists, very experienced obstetrician and gynecologist of the city of Bhopal. She is the professor and head of the Department of OBGY at Chirayu Medical College Hospital, one of the largest medical colleges of Bhopal, and also the past president of Bhopal OBGY Society in the year 21-22. She has been awarded Dr. Jagdeshwari Mishra Best Poster Presentation Award for 3 consecutive years, AICOG 2014 Patna, 2013 Mumbai, and 2012 Varanasi. Madam was awarded the Best Professor in OBGY by the World Education Congress at Bhopal Education Leadership Awards recently in 23. She has special interest in high-risk pregnancy and medical education, and we know she is a very keen academician, a very good teacher, and very loved by her students. So, Anjali ma'am, the stage is all yours. We'd like to have a few words from you, please.
Good evening, everybody. Namaskar to all the seniors. It is a pleasure to be on the platform. Sheshaya sir, my regards to you. I think I need to congratulate and say thank you to Dr. Monica because she is giving me this platform to be on the screen with you all. Thank you very much. And rightly said, the terminology needs to be used now is hyperglycemia in pregnancy because many times with small interventions, patients are able to control their hyperglycemic stage and they are able to control not going up till the GDM stage. So rightly pointed out by sir, the scare of being known as a gestational diabetes is really very bad. With use of this particular terminology, we can take care of the patients in a very loved fashion. And we all are aware that India is the capital of diabetic patients. So taking care of pregnant patients, not allowing them to go up till the GDM stage and over diabetic will definitely the change in scenario in coming days. Thank you again for having me on this platform and all the best, Dr. Monica, for your Synergy series. We are very happy. We are so proud of you. Being in Bhopal, you are taking care of so many things at one time and making Bhopal to rise more and more on national and international forum. Thank you so much.
Thank you. Thank you, Anjali ma'am. You mean a lot to us, all of us in Bhopal, and we always look up to you for your guidance. Since we do not have a special guest today evening, our special guests are Professor Dr. Ashok Kumar, President AOGD, and Dr. Indu Chawla, Vice President AOGD. They are there with some other commitments. So I would just share take 2 minutes to have a few words of wisdom from our seniors present here. Dr. Sumitra Yadav ma'am, Dr. Alka Pandey ma'am, and Dr. Sunita Chauhan. Dr. Sumitra Yadav and Sunita Chauhan ma'am have joined us from Indore, and we would like to have a few words from them.
Firstly, I would like to compliment you, dear Monica, for keeping such a nice topic today. This is a topic that is actually of the time because we are seeing a massive rise in the hyperglycemia of pregnancy, as you have put it, and also when we are diagnosing, we are actually finding out the cause of many of the abnormalities. So I feel that this should have been more widely publicized, and we, not only me and my PGs, other people should have also gained insights from it. It is really commendable that you invited sir, and it's really nice to read his CV. I'm so proud of you, Monica. All the
Thank you.
best.
Thank you, Sumitra ma'am. And Dr. Sunita Chauhan is secretary in the Rops Gynae Society, the largest OBGY society of Madhya Pradesh, as far as the number of members is concerned. Dr. Sunita, are you there?
Yeah, I'm there, and I want to congratulate you for a beautiful starting of this year. And the gestational diabetes is very close to my heart because I suffered from gestational diabetes during my pregnancy. So, congratulations to you and
Thank you.
welcome you.
Thank you, Dr. Sunita. Thank you for joining our program. And I would like to now have a few words from Dr. Alka Pandey, ma'am. I'm seeing her after a long time. And madam, we would love to hear from you. Ma'am, you're muted.
Thank you so much for this opportunity, and congratulations to Monica and Picky also. She is behind hyperglycemia, and she is, and we also are ardent, say, devotees of Dr. Sesaiya, and it is very nice that you have arranged this meeting, and it is an honor to be a part of it. Thank you so much.
Thank you. Thank you so much, ma'am. So since we will listen to you, Manoj, for your talk, I think we will start with the first session. And before the session, I would just like to give credits to my coordinators and, of course, my convener, Madam Dr. Picky Saxena. Dr. Picky Saxena, can I speak a few words about her? Can I have her? Yeah. So as you can see, this program has been put together. Dr. Picky and myself, we were talking since the last week of November, I think. The first time we talked was last week of November, and ultimately we could get this show ready by 1st of February. That is what it takes when you are busy, in practice and in medical college and in conferences. She also attended so many conferences. I also attended so many conferences, but ultimately we got this show together in the comfort of our home. We are listening to the best speakers. So this is the best part of webinars. Madam is heading the OBGY unit of LHMC, and we can see how dedicated she is, not only in hospital management, clinical research, but she has been a gold medalist throughout. I've gone through her CV, more than 250 published articles, more than 450.
Thank you, Dr. Monica. I think that is enough. And we have three more stalwarts from the DIPSI Society. We
Yes,
have
ma'am.
Dr. Rajiv Chawla, we have Dr. Bhavtani, and we have Dr. Shalini Jaggi. So let us hear from Dr. Rajiv Chawla now. He's the past president of DIPSI, and he's done so much work, and he's always in the forefront organizing all the academic activities for DIPSI. So,
Yes.
sir, it's an honor to have you. And please say a few words of wisdom.
Thank you, Dr. Picky. It's an honor to be part of this very light meeting on hyperglycemia and pregnancy. To have stalwarts like Professor Sheshai and a lot of people from gynae lobby. I may not know personally everyone, but Dr. Monica Singh, Dr. Sunita Chauhan, earlier two guests and guest of honor. So it's a very, very privilege to be part of this very, very important webinar or a CME which is being arranged virtually. And I'm happy that we are here to hear from Professor Sheshai once again on his own insight into the topic of gestational diabetes, that if you intervene early, probably primordial prevention is possible today. And what he's going to talk about today is something like, can we have a generation which will be free of diabetes and NCD? So over to you again.
Thank you, sir. Thank you so much. Pleasure to have you with us. Dr. Bhavtarni, Madam is another founder member and actually devoted to DIPSI. She's been involved in so many studies and always giving us the right insights about hyperglycemia and pregnancy. Ma'am, 2 words.
Thank you, Dr. Vicky.
Madam has been conferred upon Lifetime Achievement Award by
Yes.
DIPSI this year. She is going to
Congratulations.
deliver that oration and keynote on 9th of March.
Thank you.
Congratulations.
Thank you, sir. Thank you, Vicky, for the wonderful opportunity. I just want to say our mentor, Godfather, is a man of 4 vision, because he was the one who first came to know that diabetes is going to rule the future, and he started the department first in the country on government side, and he also wanted more people to enter into it, and he started the diploma in diabetology for the first time in the country. And he is the one, after doing all this, he was not able to bring down the incidence of diabetes, so he was focusing on the root cause, that is the GDM. Even after controlling GDM, he was not able to bring down the incidence. Now he has gone further and further, which is going to be the future. Unless otherwise we do all this, we cannot prevent all the non-communicable diseases. That is what he is going to mantra, what he is going to give today. Let us listen to sir what he is going to say.
Yes, definitely. Thank you, Dr. Bhavtani. Thank you so much for being there.
Thank you, all dignitaries. And now I just would like to, don't show the CVs, Vishal. I would just like to thank our 3 coordinators. Dr. Purva is there with us. Dr. Nandini Singh is there dealing with some patient in emergency. She'll join. And Dr. Neetu Mishra from AIIMS Bhopal. These are the girls with whom I work. They are all very dynamic gynecologists and do a lot of academic activities with me. So thank you, all 3 of you. And I request Purva to start session number 1 with none other than Dr. Seshaya sir.
Thank you so much, ma'am. So moving forward for our academic session, which is on hope and scope for diabetes-free generation by none other than Dr. Professor V. Seshaya sir. I invite the chairpersons, Dr. Rajiv Chawla sir, Dr. Sumitra Yadav madam, and Dr. Monica Singh ma'am. Dr. Rajiv Chawla sir is Senior Diabetologist and Director at North Delhi Diabetes Center, New Delhi. He is Honorary Professor in Jaipur National University and Visiting Professor in JLN Medical College and KLE Academy of Higher Education. Sir was past President of the Research Society for Study of Diabetes in India and past President of Diabetes in Pregnancy Study in India, DIPSI. Sir is a very dynamic person
Okay,
with
Dr.
lots
Purva,
of...
you may start, please. Yeah, you may
Thank
go
you.
to the next CV. Yeah. Thank you. Thank you for all those kind words.
Thank you. We welcome you, sir. Next, we have Dr. Sumitra Yadav, madam. Madam is presently professor and unit in charge in the Department of Obstetric and Gynecology, MGM Medical College, Indore. She is presently the president of Indore Obstetrics Gynae Society. She has a vast teaching experience of more than 33 years and has been very dynamic and organizing scientific chairperson of AICOG 2022 and workshop in charge. She was organizing secretary of ISAR and MPOX 2019. Secretary in of Indore OBGYN Society, and she has many awards to her credit like HIV Utkrisht Seva Award, Nari Shakti Award, Nai Dunya Naika Award.
Okay. I was busy in some another. Suddenly the call came. I think that is more than enough.
We welcome you. ma'am.
Yeah. Thank you.
Next, we have with us Dr. Monica Singh, ma'am.
Okay, it's okay. Let's proceed. So, Madam, would you do the honors? Yeah.
Yes, it is indeed the supreme honor, I should say. In fact, I'm so happy to read his CV. The question is not of being a Padma Shri awardee. It's not been given just by connections. It has been given for his incessant work that he has done. And imagine establishing the first department of diabetology in India at Madras when I was too young. I was just reading that and I was wondering what was his thought process. I am really stunned by reading this. And I think he was in army too. So I feel so proud that we have kept him today. because I'm from the armed forces background, and he's also the recipient of Dr. B.C. Roy Award. That's the ultimate a teacher can think of. So, and he has also had a Lifetime Achievement Award by the International Diabetes Federation in 2017, the first Indian to receive that. What a brief CV that he has put. I think nobody can surpass it. Welcome, sir, and it is an honor to have introduced you. Thank you, Monica, for giving me this chance. Thank you very much.
I think sir,
Dr.
sir, is,
Chawla,
sir, sir is a living legend today, and one person who has seen his own work getting acknowledged across the globe. Other day I was talking to him and we were discussing certain points, and he was telling me that most of the international organizations have also acknowledged DIPSI criteria for diagnosis and management. And over last 50 years, he has been working on that. He's a father, something like fatherly figure in gestational diabetes in this part of the world. And to us, he's not only a mentor, but also a godfather, sort of guardian to all of us in this part of the world. So over to you, sir.
Thank you very much, Raji. I'm
Thank you,
happy that you are going to be chairperson. And I will, when they called me for this meeting, I immediately accepted because I love to talk to people. I love to meet the people to listen to my talk. Let me see now. Now, I told in the my biodata, 1978, yeah. Now we'll see this. I don't know whether you can see this book.
Yes, sir. We can see, sir.
You know when it was started? How poor I was. Look at this book. It was, I never said GDM. You see here, effects and control of glucose intolerance on fetal placental matter unit. I don't think anybody would have thought about the title here. It was given in 1982. Professor Sasha was publishing this book. We don't have this. Those days, very difficult to get printing. This is what I did. But this information, as Badhan was telling, this is basic science, basic outcome which I published there. It is still with me now. It is an ancient book. We'll see now. Now, I am going to speak in this topic, hope and scope for diabetes-free generations. Now, this is because, as I told you, generations I want to avoid diabetes. Now, we'll go on for processing of my talk now. This is the institute in the Madras Medical College, belongs to Madras Medical College. It is the IGMOR. It's purely for the Obstetrical Institute, Women and Children Hospital, IGMOR, Madras, 1889. We'll imagine how old it is, pioneer in Asia. In that institute, I also studied, where we started fetal-placental matter unit in 1980. Combined OBG and diabetology clinic, first in India, second in the world. Professor Samji was my guru, Professor Sashriya and Professor F.S. Phillips, we all joined together, started this clinic that is called fetal-placental unit. In this, I told you, the first work we did was spot test for blood glucose in pregnancy, because those days, very difficult to diagnose GDM because 3 tests, 4 tests, 100 milligrams. Sullivan Mahan, counter question, so many people are working because they're all white people, they know what to do. But we cannot afford to do so much of tests. So that is where we started this spot test. But so happy, in those days itself, these reviewers were able to accept our paper. It was published in the first paper of mine, Journal of Obstetric Gynecology in India, 1986. Now, after that, spot test, because we never gave any glucose. It is only the meal. So, the meal-related test, that one. Now, next came will be a single test procedure to diagnose GDM. In 2009, the Acted Diabetology was published, and then following that came this is important now, early gestational glucose. I never called GDM at all. I told you that dangerous to call GDM, early gestational glucose intolerance. Curious 22, you published it, and then primordial diabetes, and again 24. Now, finally, we are now, as Bhavani was telling, hope and scope for diabetes free generation. That is what I'm thinking. That is my dream. Hope you all able to make it true. Now, we just introduction, estimation, and projection of the number of people 20 to 79 years with diabetes in different conditions, millions. 2019, it was 463 million. In 2021, it became 537, that is 16% increase. In 2040, it is going to be 783 million, that is 54% increase. So it goes on increasing. And population also increasing and diabetes also increasing. Now, pre-diabetes approximately 380 million, which is likely to increase to about 480 million by 2040. So everything is increasing, both diabetes and pre-diabetes. So the diabetes is epidemic of unprecedented magnitude. That's what we thought. Now it became pandemic. So that is introduction I'm telling. Now what we can do now here to get this problem. So when you screen diabetes, detection diabetes does not mean prevention of diabetes. What we want is here primordial. What we need is primordial diabetes. That is, disease should not develop. That is our motto. That is our aim. Hope we will succeed. And then what steps can be taken for primordial prevention of diabetes. Now I'll discuss the steps to be taken. Now, most commonly detection of GDM. This is what we use. Detection of GDM is possibly by very diagnostic number of things. You can DIPSI, IAD, PAG, so many nice. No limit for the diagnosis of GDM. What we are concerned is we are prediction. Once you know this kind of prediction, we can take the we can control the diabetes. Prediction is the at which week, not month, at which week and glycemic level development of GDM occurs. Which week? That is a message. Very important. This more specific. Finally, prevention, detection, prediction, and prevention where is a measure to avoid the development of GDM and its consequences. Now, detection of diabetes is very, very important message here I'm going to share now. You will see here diagnostic criteria in studies used for the estimating gestational diabetes. Any number of the world criteria are there. If you look at the list of this to diagnose GDM. Now, what I want to specifically discuss here is this important slide here. The first thing will be IAD. Most of us are talking IAD-PG without realizing what happened. Here, I am sharing the important message which I know him. Boyd Metzer. He has come to Chennai number of times. Twice he had come here. IAD-PG guidelines have become obsolete. The author of IAD-PG guidelines, Boyd Metzer himself, has recently commented that even at centers that accept IAD-PG recommendations, the approach varies and needs revision for standardization of the strategy for diagnosing GDM. So it is a pity in our country. Still, people want to call IAD-PG. When himself authors stopped, now we are still want to follow this. Anyway, we'll see what happens here. Now, another message I want to share with you in the America itself, ADA, ASVG, both are different category. Here, this is what happened. Different countries have different guidelines for diagnosis of GDM. In the same country, like the United States, has two guidelines which lead to confusion among the healthcare professionals. So what is the answer for this? This is removed. Cut it off. We don't want to have that. Otherwise, it goes on. How many confusion is there here? So, therefore, the physiological glycemic level in normal pregnancy has to be recognized and implemented. It's very simple. Physiology is important. What it is, this is showed here. Pattern of glycemia in non-pregnancy. This is a wonderful outcomes study here. The 2-hour PPG is 110 milligram. It should not cross. It has to be less than 10. That is the physiology. That shows in pregnancy, you should always see any woman in pregnancy, blood sugar should not cross 110 because it has to be like that. Suggested postponed target, physiological target. That is why any value above normal is abnormal. So this point is made clear here, and you should not give any other guidelines should be year afterwards taken up. You have to insist only on these guidelines. Now, that particular thing, now another topic I'm going here, embryology of beta cell development. This is very important because if you look at the islet cells, each islet cell functions as an endocrine organ. Because of that, pancreatic islets recognizes and responds to maternal glycemia at 11th week of gestation. So 11th week is the beta that starts secreting insulin. That is a very important week, 11th week. So this is another point here, glycemic level at gestation weeks for prediction of GDM. Please remember the prediction, prevention, intervention, the three, the prediction here. First time in National Institute of Health study in 2018 suggested A1C of 5.3, there is 2 over ppg more than 10 milligrams. At the 10th week, predict GDM. So that when you do the 10th week, you find the blood sugar level postprandial in the mother, in the would-be mother, more than 10 milligrams, it predicts GDM. Not all those 140, 140, 200, all forget about it. Simple, only thing is physiological content, 10th week, predict GDM. So, hence, prevention of blood glucose has to be brought to less than 100 milligrams. More than 10 is going to be predict GDM. So, what we have to do, prevention test about less than 10 milligrams as fetal beta cell start secreting more insulin on 11th week. So, 10th week prediction, prevention has to be brought less than 110 so that you have to be careful to bring it down to fetal hypertension occurs at 11th week. So 10th week and 11th week and blood sugar is 110 everywhere. So, but so far, no further work has been done for the prediction as well as for the prevention of GDM. This is all theoretical, but no practical done. So that now we are entering the field. Now, this is a summing up now, conceptualization, putting both endocrinology and embryology. Maternal to or postpartum blood glucose, blood sugar should not cross 110 milligrams at 10th week, as fetal beta cell start secreting insulin around the 11th week of pregnancy. So 10th week, if the blood sugar going up, 11th week, fetal beta cell start secreting insulin. This should not occur. This is what main message. 10th week, fetal beta cell start secreting insulin and 11th week of pregnancy. So now, if you look at another step, maternal hyperglycemia and fetal hyperinsulinemia, that is the most important message here. The obvious implication is that glycemic control needs to be optimized very early in pregnancy to prevent the establishment of fetal hyperinsulinemia. So always remember this message, PPBS should be less than 110 milligrams. So now next step will be the fetal handling of maternal glucose. I told you, maternal hyperglycemia, fetal hyperinsulinemia. So the fetal handling of maternal glucose, what fetal does here? Suppose example here, suppose a woman, pregnant woman comes to our OP department and 10th week, if suppose we see the blood sugar, it's going to be PBS 126. This probably, unless now people are not aware of this value, 126 we also ignore it, so don't worry. Then what happens? We go down, 12th again after 1 month, lady comes back to the OP department, PPBS comes down without any intention. So the doctor who was looking at that, they're very happy. Okay, you had under 126, now 110, nothing to bother. Then what, this is the mechanism here. 126 became 112, thinking that nothing is happening, it is worst thing happened here. We hear how, now this is what happened. 11th week, what happened here? More secretion of fetal insulin starts. This brings down the maternal glucose. So fetus supports the mother's glucose. So when you do the test, it will be normal, but actually the fetal blood sugar going up. So this is what could happen here. Maternal blood glucose does not go up due to fetal insulin handling of the maternal glucose. That is what we call maternal glycemia starts increasing at the 10th week. More fetal insulin starts secreting the 11th week. It's irreversible. It's over. They're finished. If we miss the 10th week, after that nothing can be done. It is irreversible. That means that lady will become GDM. Now she is not GDM. Now only abnormal glucose tolerance. That is why I never use the word here GDM. I'm just telling you irreversible. So next part will be guidelines to screen glucose tolerance at appropriate gestation weeks. We told here 10th week and 11th week, which week we should talk. Here, again, weeks 10th week, 11th it goes on. 10th week, suppose postprandial blood sugar goes more than 10th week, what could happen will be here, fetal beta cell insulin secretion starts and continues from 11th week onwards. If it is 10th week itself, cross 10. 10th week is less than 10, nothing would happen. Unfortunately, more than 10, 11th week, fetal beta cell insulin starts secreting and continues. Because of that, what could happen will be here, glycemic control needs to be optimized very early in pregnancy, prevent the establishment of the fetal hyperinsulinemia. That will be again repeating, maternal hyperglycemia leads to fetal hyperinsulinemia. This is like a mantra, goes on. So, but what is happening in any test book, you see, usually screening for GDM is done at 24 weeks, but should not happen now. Now we must change our ideas and go here. From present studies, it is recommended to test for glucose tolerance in the earliest pregnancy, that is early gestational glucose tolerance. That is, please do not call, some people call EGDM, early gestational diabetes. No, that should forget the terminology. EGDM. You use only early gestational glucose intolerance. So now contribution of glucose gradient will be this is a little bit of physiology here. Again, maternal glucose goes up. What could happen? Maternal hyperglycemia pushes the glucose into the fetal compartment, and fetal hyperinsulinemia pulls the glucose. That's why when the fetal cell, insulin secretion goes up. Because insulin goes up, again adiposity. So the fetal glucose chill across the placenta to the fetus. So again, the message will be here: maternal hyperglycemia and fetal hyperinsulinemia promote fetal adiposity, results in the offering will be here. The child is born, male child, obesity, IGT, diabetes. As female, obesity, GDM, and diabetes. So the vicious circle goes on. So now finally, now we are going to do. Ideal is test for the glucose tolerance at the 8th week. It's because I told you earlier itself, 10th week is a problem. So we must anticipate. So ideal to test for glucose tolerance at 8th week at 2 months. Why? Why is it 8th week? Because prediction of GDM is 2 over ppbase milligrams at 10th week. That is prediction. So what we should do, we anticipate here. Yes, at the 8th week itself, 2 over ppg has to be estimated. If less than 10 milligrams, follow up by monitoring CBG. In case it's going to be more than 100 case, 2 over ppg more than 110 milligrams and less than 119, at the 8th week, what should be happen here be a grace period of 2 weeks available, fortunately, to attain the 2 over ppg less than 100 milligrams at the 10th week with MNT and metformin. So this beautiful message here, 8th week screen, 10th week bring it down to 110, so nothing will happen. Because 110, if it's more than 110, 11th week is beta cell start secreting. Now we'll see what happens. Now what we can do will be here, early gestational glucose tolerance and intervention. See, again, one more example I'll give you. 8th week, more than 10. That's what happened. What in this time, if the intervention is given with the MNT and metformin, 10th week, fortunately, it comes down to less than 10. That's what we aiming it. With 8th week itself, we start eating, and the 10th week, it comes to less than 10. And the 11th week, grace period of 2 weeks available and normal. now 12th week, all these weeks, no problem at all, everything is fine. Now, in case here, 10th week happens to be 110 milligram and above, you cannot do much in this woman. Not enough time is available to achieve less than 110 milligram at 11th week. So everything works only in 10th week. Anything goes wrong, we cannot revert back here. So fetal beta cell starts secretion. So you will always, the mantra will be maternal hyperglycemia, fetal hyperglycemia. That's what everywhere is what's happening here. So fetal beta cell secretion starts increasing. Nothing can be done outwards. So what we can do will be now a fetal pregnancy will be embryonic stage will be here. In the 8th week, embryonic stage. 8th week is, as I told you previously, how it is important. The safe period time will be 8th week here, because in 2 weeks, 8th week, embryonic stage. After yellow line, it becomes 9th week, birth fetal stage. So you are going to give treatment for that woman in the embryonic stage itself, 8th week before. Nothing will happen, because after 8th embryonic stage, you will not do any harm by giving any treatment. We can do the treatment. That's why you give here. If more than 10 milligram, MNT and metformin 250 milligram, PD has to be started and continued. The target glycemia to obtain this will be 2-hour post-mortem blood sugar will be 99 plus or minus 10. That should be our target. This treatment can be given. Now what will happen? Metformin is safe as embryonic stage is over by 8th week. Nothing will happen. You get safe time when you after 8th week you give it. So metformin is safe for use throughout pregnancy. Glucophage was approved as the first oral antidiabetic medication to be used safely from conception to birth. And now what happened? Even in the Apollo hospital in the Delhi, where the fellow here, Yegni, who was always talking ill about metformin, now this fellow published this paper. His name is there. Anyway, this I just mention here, long-term impact on offspring, 5 to 10 years they have followed up, nothing happened by giving metformin. So friends, here the subject expert committee will be following the review. This SCEC has recommended the consideration of metformin, SR 500 milligram and metformin 1000. They say it like that, but in our practice we found 500 milligram per day is enough, 250 morning, 250 night, for use during pregnancy as a treating physicians and discussion as an adjunct and alternative to insulin therapy. So please tell this government, or go on arguing with us, metformin, don't give metformin. Now government also given, so the safely you can give metformin during the pregnancy. You can start from 8th week itself. So in case, this is a message, initiation of metformin after 12th week will not be effective in preventing bleeding. Over. So anything should be 10th week, but they give this study has shown after 12th week, after that nothing will happen, that lady will become GDM. So now I am going to share with here what is theoretical and economic and physiological also. Now we will see in the pregnancy pregnant woman, prevention of GDM by treating postprandial blood glucose more than 10 milligram in first time method, because Saxena is one of the CEDs that work, Lady of the Medical College. This is a wonderful outcome here. Women enrolled 117. 2 missed abortion, 4 lost follow-up, then ultimate and 117. Follow-up till date. What happened here will be the out of 117, 99 developed GDM, that is 84%. That clearly shows more than 10 million is so dangerous. Now, here what happened here without metformin. Now, suppose here women enrolled same 119, 3 missed abortion, 3 lost follow-up, following up till date, only 1% developed GDM because with metformin. So this is greenish, metformin, here without metformin. This study has clinically proved. Why anybody should have doubt on this? I think this is how to impress on the people. I think you all must work for this and tell the government you can use this drug to prevent GDM and as well as prevent the child becoming diabetes. So results so far indicate the TAP metformin 200 mg BD significantly prevents development of GDM, even with 2 hour PPG, more than 10 mg at 8th, 9th week. Now, again, they have found beautiful work here. The area within the ROC curve for PPBS was 0.969, indicating excellent discriminatory power for entering GDM. Similarly, the AUC for HbA1c was 0.916, demonstrating positive predictive performance. That shows the study showed excellent outcome. This conclusion, the very beautiful conclusion PK has done. PPBS more than 10 mg at 2 hours exhibits high levels of diagnostic accuracy for the prediction of GDM and is associated with adverse fetal-maternal outcomes. PPBG is a superior physiologic low-cost option compared to HbA1c. We don't recommend it all for early prediction of GDM and can also be performed as a simple point-of-care test, the glucometer at home or in the periphery by healthcare workers and in wellness centers. So this study has showed clinically they're not necessary for us because of not affordable. JVC can do in the like a Priyaganj, go and do that. What will do? It's not possible A1C. So here, glucose hemoglobin A1C, WHO guidelines, this evidence is there. The WHO guidelines does not include A1C as a means of diagnostic diabetes in a pregnant woman and for monitoring. You see, all of them will be a number of people are in the WHO guidelines. And then use of glucometer standardized. Please, this also don't tell me I'm promoting it. I have found you must use a very good equipment, glucometer. Accuracy is the best. We have done published that also here for measuring the plasma glucose. So there's some number of impression I'm sharing with you now. Now we have also done in Chennai. That means say one center can do, but how will you know what happened on other centers? So happened in Chennai also. It was done in the Madras Medical College where Antarakshi was working there. Group A, non-metformin group, the 2 hour PPG less than 10 mg/ml. 82 enrolled, and in this 1.2% developed GDM cause may be multipara, non-metformin. Here, group B, metformin, 2 hour PPG more than 10 mg, and then 69 women enrolled, and 1.4% developed GDM. This shows in the intervention of one woman only, 1.4 developed GDM. That too because she discontinued metformin after 6 months of gestation. This clearly shows that there is a great scope for the prevention of GDM and non-common diseases, as Picky told in the previous slide. So both Chennai and Lady Harvard Medical, similar results have come up. So newborn birth weight also, birth weight less than 2.5, no one more than 3.5, and again no one again to less than 2.5. So all the outcome is so good in all these studies. So summing up, in public health, this again I want to share with you an important message. In public health domain, 2 hour postprandial blood glucose is plausible than 2 hour post glucose blood glucose. That means never recommend 2 hour post glucose. Recommend only 2 hour postprandial. That's what I told this red color glucose. They're prandial. That's what happening. That's what should happen now. I also showing a number of studies have shown development of an easy to use point of care, non-fasting, non-glucose load dependent test may make consensus easier to achieve in the future. More sure. He's a very great fellow. And then here, postprandial glucose, she never said glucose, postprandial has been reported to be the best predictor of the fetal-maternal caliemia, the Louis Jonas, a very great lady in States. And then National Institute of Health, as I told you earlier, 2 hour PPG less than 100 mg. And then lately here in the Curious paper we published prediction, and both we did prediction prevention of GDM, 2 hour PPG more than 100 mg. So all these things occurs we give glucose. So it is better to give only meal or. So now what happened here? So if percentage of mother undergone the OGT test for detection and the DDM. So when you follow them up like this, 2010, 16% they could do the OGT, 21 to 15.5. Lately, it is about 2. This is published government of data. Only of 20% only they are able to screen with OGTT. Then whereas here in Bhavadani Center, real world situation here, again last line, 82% of women were in the non-fasting state. So it's, we don't mind, we lose the test. But what happens is some government organization, they said, no, you go and come back. Next time when I asked them to come back, what happened? This is what happened. The dropout rate is very high when a pregnant woman is asked to come again for the glucose tolerance. So that means that is why we are telling any woman who comes in the fasting and non-fasting after the meal, please don't send them back home to do the blood test. So finally, categorization of glycemia during pregnancy. Here, GDM, all of us know, glucose-based. This is 2 hours post-PT will be more than 140 milligram. Future type diabetes, they're sure about that. And then DDA will be here, glucose-based again. 2 hour PPG will be 2 hour PG, 120 milligrams, to 140 adverse pregnancy outcome and future type diabetes. These two things we are not interested here. What we are worried, what we are concerned will be here, early gestation glucose intolerance, that is called EG, 10th week PPV is base. 2 PPG more than 10 milligram, prone to develop GDM in the future IGT. So you must always control less than 110. Finally, normal glycemic pregnancy will be 2 hour postpartum PPV will be 99 plus or minus 10. The figure 110 always we should remember. Less than 110, it's very safe. More than 110 is risky unless we introduce metformin. So this final message, prediction of GDM, 2 hour PPS, more than 10 milligram at 10th week, prediction. Then second point, preventive action has to be taken at 8th week so that maternal PPS remains less than 100 milligram throughout pregnancy. That's what the difference between prediction and the prevention. And finally, here intervention, MNT and metformin to continue until confinement, follow-up essential of delivery. So this is the final message what I've been talking now here. Then we also published in the journal Cures the technical report where we gave this to prediction, prevention of gestational diabetes and its sequelae by administrating metformin the early separately. It was published. After this publication only we start doing the work in our PK Saxena and Anjalakshmi we did in the Madras Medical College. Now finally, aim to maintain maternal to plasma glucose 99 plus or minus 10 throughout pregnancy. That should be our aim. From conception to confinement, 2 hour PPG should be 99 to 109 milligrams. If that is happens here, monitoring is very important. 2 hour PPBS at weeks. 8th week is the correct. Suppose they miss, at least 9th week can do it, but ideally 8th week, option 9th week, then this is what happened, 10th week. This 3 with message 8th, 9th, 10th should be screened. Until women likely to visit clinic regularly, tell them come. 12th week if they come, there's no point. Not necessary, and metformin won't be useful. She will develop GDM. And 16th, 18th, 43, you can follow up to check for GDM by DIPSY criteria, water criteria. You want to screen. Most important will be 8th and 10th week. Other weeks and all may not be necessary because this is what you have done. It already you passed. So now sequence of events and entered weeks. 10th week prediction. I'm repeating a number of times again. 10th week prediction of GDM. 8th week screening in anticipation. 11th week fetal blood cell sensation second start, and 12th week finished. Treatment not effective. So this number, 10th, 8th, 11th is most useful number in the pregnancy, prevent GDM. So it all starts in utero, now ends for diabetes-free generation, focus on the fetus for the future. And also now I'm telling here, now I am so happy to share with you our publication. You see the countries, Australia, China, Europe, number of countries have taken our publications. I never knew. It came only about 2 days ago it came, 11 o'clock. So we are happy that other countries also trying to follow our own work. We'll see probably what we are doing in the India may go in the world also. Because so many countries have followed. The name V. Sashaya was cited in a clinical sentences paper uploaded to academia. So friends, by prioritizing women's health and implementing evidence-based strategies for GDM, prevention and management, we can pave the way for a brighter and healthier future. So hope and scope for diabetes-free generations. And finally, I'm happy to share with you people again, congratulations. Somebody asked the haters to me, congratulations on your achievement. We would like to thank you for your contribution to the scientific community and for ensuring research is freely available to readers all over the world. I'm happy you also should be able to approve my work so far. Thank you very much. I'm very happy for your passion, listening. If anything you want to discuss with me, please discuss. I am willing to share with you. Thank you very much.
Thank you very much, sir.
First.
Over to you, Dr. Monica.
Yes,
I think this being an oration and a keynote lecture, I don't think we need to have any questions. Everything is so well said and absolute clear insight sir has given to everyone. So I don't think there is any scope for any question or for any comments. So over to you for further proceedings.
Thank you, chairpersons, and we just are mesmerized by the talk, Professor Sashaya, and we are a blessed generation to be able to listen to you live, and the thought process which has gone into your work in 1980s to present. I mean, you are a living legend, and if we can get this message across of the 8 weeks screening across all medical colleges in India, across all OBGYN specialists, I think we will go a long way towards attempting to eradicate diabetes. So thank you so much, sir. Vicky ma'am, would you like to speak a few words? Ma'am, you're muted, ma'am. Ma'am, you're muted.
So I think sir had given this idea, and we all thought that carry it out and see if this hypothesis holds true. Really, we were amazed to see that the woman who received metformin, hardly 1 or 2 women developed GDM, whereas all others in the other group who had not received metformin and had postprandial blood glucose more than 110, nearly 95% developed GDM. So it is proof of concept, and I think it is a very simple and doable thing. As sir showed, it is a physiological test, can be done as a point of care just by a glucometer. And the ASHA workers can go to the home of the patients, and just at 2 months amenorrhea, they can do this test. And if it is found to be higher than 110, easily they can start on metformin, and this will go a long way preventing not only GDM, but also intergenerational transmission of GDM, childhood obesity, diabetes, all these complications. So I think what sir has said, whenever I read into GDM, I always find so many papers sir has looked into, I think, all aspects of GDM. I think we will be talking about it in the panel also, but it is just, a very, very great thought, and coming from an Indian. Now other people have started following and they are talking about early GDM. Tipsy way back had said that testing of blood sugar should be done in a non-fasting state, and that too at 8 weeks of first visit. And now other people in different countries are coming up to the same thing after, I think, about a decade later. So I think Sir is a great visionary, and even at his age, he thinks faster and quicker than us. He's the one who is reading up lot of new papers and coming up with such brilliant. So I think we need to all join hands and try to bring down the incidence of not just immediate perinatal complications, but also primordial prevention of diabetes, obesity. There is a pandemic of all these non-communicable diseases. So this test and this intervention has the potential of reducing it and preventing it. So it's a way forward, and I'm really thankful to Sir for guiding us, for giving us all the Dipsy family for coming together and thinking of this study and helping us to carrying it out in Lady Harding.
I think
Thank
Dr. Picky very rightly said is very easily doable. And
Yes.
what Sir said almost 3 years ago is almost proven in both the studies, whether it was his own Dr. Anjalakshi's data or your data from Lady Harding. Both the studies have proven that if you add metformin 250 milligram BD, it not only gets you the prevention, of course, the long-term benefits in terms of offsprings developing, say NCD will be proven later on, but immediate benefits we have seen that it prevents conversion to GDM in the index pregnancy itself. But unfortunately, in spite of this also, you know it that we are still facing a lot of resistance for adding metformin as low as 250 milligram BD also as a prophylactic drug. So I think all of us, we must have to, will have to join hands, both Dipsy and Foxy, in taking this proposal or pilot project forward so that it gets universally accepted, and maybe tomorrow it becomes a standard care that you do a screening as early as 8 weeks, and if there is a hyperglycemia only say by 3 milligram or 5 milligram and you add metformin after MNT trial of 7 days, and probably it may do wonders in terms of prevention of GDM in the index pregnancy, and may be useful also in terms of long-term prevention of NCD in the offsprings.
Thank you, Dr. Chawla. Sumitra ma'am, would you like to speak a few words?
Yes, I would like to be very frank. I've got a very bad habit of being always very frank. I learned quite a lot today. I'm so happy. I learned a lot which I can pass on to the students, both MBBS and PG. And I'm sure this will go a very long way in preventing diabetes in the coming generations. I'm really grateful that I joined this meeting today. Thank you, Monica.
Thank you, ma'am. Sir, a lot of gratitude from Team Synergy and AOGD on behalf of myself and Picky ma'am. We were fortunate enough to listen to you, sir. Well, not once, but twice, just because of Picky ma'am. Thank you, Seshaya, sir. Thank you so much.
Sir.
Thank you, sir,
Thanks a
very
lot,
much, sir.
everyone.
Thank you for taking out time for us.
Thank you.
It's because of you. I won't know.
Thank you so much, sir. I have your special blessings, and I'm really, really thankful to you and Dr. Chawla, Dr. Bhavtani, all the Dipsy family. Thank you very much.
And we are not leaving you. We are again catching you on 9th of March
Yes,
in
sir.
Hyderabad.
Be a pleasure.
By the time, what I've
for a
done
keynote lecture again.
we'll develop more by the time.
Yes, sir. Sir, my other paper is also nearly ready, and we are ready with all the early neonatal complications, the obstetric complications, everything, cesarean data, and everything is ready now with the statistics. So we'll be able to take it further soon.
So, Picky madam, does the ASHA worker who visits the pregnant woman in the village, does she carry the AccuCheck?
Dr. Monica, this has not come into practice. But in Lady Harding, after I came in contact with Sir, what we have done is we have made a Dipsy room. And every patient who is coming for the first time to Lady Harding Medical College has to go through that room. She is given 75 grams of glucose in 1 glass of disposable glass of water. And by the time she comes back after getting her tetanus, PA examination, obstetric examination, sister notes out the time. And we are using AccuCheck glucometer, and we use this test. She, besides having egg chapati or 1 apple or 2 slices, what we found was that this postprandial test was really very good. And we have also replicated it and seen it in comparison with venous sampling in few of the patients. And what we found was that there was a difference of only 5 to 10 milligram, which is not a big thing. But it is so much doable. It is a point of care testing, which we are routinely doing in Lady Harding, where we have sometimes an OPD of 400 patients every day. And it is not easy, even in sitting in the capital city of India, to take out the venous sample, and then the patient has to come back again for the report. So many times they don't just come back. They don't even get, that hemoglobin is also not done. So this is such a doable test, physiologic test, and can be done by a glucometer. So sir, and we all have formed a committee, and we are discussing with the government to try to implement it in the periphery also. At present, ASHA workers are not doing, only we are doing. And it has been replicated in several other centers in India. But we want to take it further and let it come in the national guidelines so it can be used by the ASHA workers. It is so simple. Glucometer testing. So that is the vision of Dr. Shaiya sir, and that is all we are all aiming at.
Thank you, Picky ma'am. Thank you, Picky ma'am. So now I think we have done the first session very, very brilliantly. Thanks to our dignitaries present here. And we can start the panel discussion now with your permission, Picky ma'am.
Yes, please.
Please. Yeah.
Sir,
Change-
can you ask that boy to stop sharing your slides, sir? Because then I can share my slides for the next. Yes.
She's going to stop.
Picky, I'll call sir and say.
Yeah.
Yes, ma'am. Now you can proceed with the panel, ma'am.
Yeah, I will just do.
So in this webinar, we are having the panel in between the two talks. And for the panel, we have Dr. Basu as our expert, Dr. Sadhana Gupta ma'am, another very, very brilliant star in the Indian gynecological sky. And of course, Picky ma'am is the moderator as well.
So are my slides visible?
Yes, ma'am. We'll just do, ma'am, a little bit of 5-minute introductions of the Purva, can you please?
Yes, ma'am.
I'll stop sharing.
Yes, ma'am. So moving forward to our panel discussion, that is case-based scenarios. Dr. Vishal, can you share the slides?
And I'm very, very thankful for Dr. Basu ma'am to have agreed to be the expert. Ma'am is so much interested in diabetes, and he's always with us. And also Dr. Shalini, who is going to be the DIPSI president on 10th of March. She's going to be the next DIPSI president, and she's really passionate about GDM, and she's working very hard in the field. So welcome to you. And of course,
Thank you, Dr. Picky.
My obstetrician friends, welcome to all of you.
Thank you so much.
And we have a stalwart, Dr. Sadhana Gupta ma'am, with us. Thank you, ma'am, for joining us. She's another person who is very much interested in diabetes. And I was so impressed when I first heard her panel about 5 years back. So welcome, ma'am, and thanks for joining.
So for, starting with our panel, we have our expert, Dr. Basu ma'am. Madam is presently Principal Director and Head of Max Super Specialty Hospital, Delhi. She is governing board member of National Board of. She is National Chairperson Committee Communication in Healthcare and Professional Development. She is Chair Advisory Board International Association of Communication in Healthcare, National Webinar Chairperson of Obstetric and Gynecology, National Board of Examination, New Delhi, Founder President Society for Communication in Healthcare in.
Dr. Purva, your voice is, we can't hear you. Can everyone else
Excuse me?
hear?
Yes, ma'am. Yes, ma'am. I'll introduce her further, ma'am. Madam is National Chairperson of the committee. Madam is National Chairperson for the Committee of Communication and Healthcare and Professional Development. Madam has also been the chair and chair in the advisory board of International Association for Communications and Healthcare, and she has been a national webinar person. She is the founder president of Society for Communication and Healthcare. She has been awarded with various prestigious awards such as Certificate for Excellence for Path-Breaking Reforms in the Field of Medical Education. She has also been awardee of Distinguished Teachers Association. She has been awarded Excellence Award by the Max Healthcare India for Clinical and Academic Excellence. She has been awarded as the Roll of Honor for Excellence by the Jaipur Golden Hospital in India. And she has also has received the Dr. APJ Abdul Kalam Award. She has also received the Foxy Achievers Award, and the list goes on and on. It's an honor to have you, ma'am.
Thank you so much for your wonderful, the webinar I've been listening, and it's an honor when all of you invited me to be a part of this very, very important, topic. It's the current, what shall I say, the flavor of the day, and it's prevention is what most required. So I'm very, very happy to be there. And thank you all, Dr. Picky, Dr. Monica, and all the others who have been. It was a pleasure to hear Professor Sheshaiah also. And I really admire the work he has done and all the work that all of you are doing now. So I look forward to this panel. Thank you.
Now, moving to our honorable moderators. Our first moderator is Dr. Sadhana Gupta, Madam. Sadhana Gupta Madam is the fellow of ICOG, and
just keep it short, Nandini. I think keep it short. So,
ma'am, just two words if you like, ma'am, please.
Yes.
She's a senior consultant and infertility specialist at Jeevan Jyoti Multi-Speciality Hospital, Gorakhpur, and though the CV is very vast, she is also the editor of manual book Safe Motherhood Initiative, a Silent Revolution unique book awarded and it has been awarded the best Foxy publication. An honor to have you, ma'am.
And we congratulate Sadhana ma'am for the ICOG Vice Chair Elect 2025.
Congrats, ma'am.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you.
Congratulations, ma'am. Congratulations. Next panel coordinator is Dr. Picky Saxena, Madam. Madam is she's a director professor and unit head, and I'm in charge of assisted reproductive services in Lady Hardinge Medical College. And she is also she is a great academician. She's a winner of 34 gold medals in national and international conferences. She's the editor of 11 books, had a vast number of publications of more than 250 articles.
Thank you, Dr. Nandini. I think you can go ahead. Thank you so much.
Thank you, ma'am. Thank you, ma'am. We all welcome you, ma'am. Now, moving to our galaxy of panelists. Unfortunately, Dr. Beenu Kushpa ma'am could not join us because of technical issues. But moving to our next panelist, Dr. Juhi Agarwal, Madam. Madam is professor and a unit head in the Department of Ophthalmology in GMC Bhopal. She has a vast publication and number of national as well as international journals. She is a state trainer for SCAC for comprehensive abortion care and FTI. And she has...
please go ahead.
Dr. Purva, Dr. Beenu can't join even on phone, on the mobile.
Yes, ma'am, she was not able to join.
Call her. I'll see what I can do. I'll just...
Thank you, Nandini, for the kind introduction. I am glad that I am part of this panel with Saul Stalwart.
Yes, ma'am. Our next panelist is Dr. Meenakshi Singh, ma'am. Ma'am is professor in the Department of Obstetrics and Gynae in Lady Hardinge Medical College. She has been trained in the point of care quality improvement. She is a national level mentor for Lakshya. She is a co-editor in NARCHI, and she is also clinical secretary. She has been the clinical secretary of AOGD. She is a member of Outreach Committee of NARCHI Delhi. She has various publications in national and international journals, and she has a special interest in high-risk pregnancy and infertility. We welcome you, ma'am.
Thank you so much.
Our next panelist is Dr. Padma Shukla, ma'am. Padma
Madam
Shukla,
is
ma'am,
not able.
not able to join today because of some emergency. Moving to our next panelist is Dr. Ritu Sharma, madam. Ritu Sharma, madam, is Professor and Head of Department in Government Institute of Medical Science, Greater Noida, UP. She has a teaching experience of more than 14 years. She has been awarded of 7 gold medals for various oral papers, and she is also the president of Greater Noida Menopausal Society. She is a member of Endoscopy Committee AOGD. She is the member of Infertility and Reproductive Endocrinology Committee AOGD. She is also the member of Project Review Committee in ICMR and DSMB. She is a member of editorial Pan-Asian Journal of Obstetrics and Gynecology. Madam has also co-authored the book Early Pregnancy Practical Perspective. She has 65 international and national publications and chapters in Obstetrics and Gynecology textbook. She has a special interest in high-risk pregnancy and preventive oncology. Our next panelist is Dr. Shalini Jaggi, madam. Shalini, madam, is the consultant and director of Life Care Diabetes Center, New Delhi. She is the president-elect and governing council member of DIPSI. She is also the chairman-elect of RSSDI Delhi chapter, and she is the Asia Pacific Advisory Board member, and also chair Diabetes and Mental Health Interest Group, Diabetes India. We welcome you, ma'am.
Thank you so much.
Thank you, ma'am.
Next is
Our next
Dr.
panelist-
Sunita Chauhan, ma'am.
Yes, ma'am.
Madam is presently Secretary of Indore Obstetric and Gynae Society. She is a very dynamic person with special interest in infertility and laparoscopy. We welcome you, ma'am. Now I hand over the session to
Thank you very much.
Next, our next panelist is Dr. Taru Gupta, ma'am. Madam is presently professor in ESI PGIMSR, New Delhi. Madam
Thank you,
is
thank you,
very
Dr.
renowned.
Purva. Thank you.
Thank you so much, ma'am.
Okay.
Now I hand over the session to our moderators, Dr. Picky Saxena, madam, and Dr. Sadhana Gupta, madam.
So are my slides visible now? I'll
Yes,
make it-
Yes, ma'am, they are.
Make it fully screen.
Yes.
One thing before I go to panel, I wish to my regards Dr. Shishaya, because 2013 when Dr. Hema Divakar was president and I was chairperson of Safe Motherhood Committee of FOGSI. At that time, Dr. Shishaya, Dr. Hema Divakar, Dr. Arun Kapoor and the DIPSI. This was the time when the FOGSI spoke of GDM in a big way. Initially, a lot of resistance from all the people, even in FOGSI, that it is not there in our country, it is not there in our country. And maybe a little bit me also, but through the time we have really gone through this thing, that the leaders like Dr. Shishaya, Dr. Hema Divakar, Dr. Arun Kapoor, and then the FOGSI leader, and even at SAFOG, the India is leading about the diagnosis, management, prevention, screening. And congratulations to Picky, Monica, Manoj, and thank you for this invite. So Picky, you can go ahead and you can start, please, the panel.
Ma'am, you have to start the panel.
Okay. So warm welcome to all panelists, and with this brilliant deliberation which speak of real experience by Dr. Shishaya, we will go through, me and Picky, with the real ground realities and how the clinician get confused. So the first question, Binu is not there. We will, Juhi and Meenakshi. Yes, so Juhi and Meenakshi, that you offer universal testing or any history indicated testing, and at what period of gestational age you offer screen for GDM? So patient might be coming to you with 5 days UPT positive, maybe 6 or 8 weeks, or maybe 12 to 14 weeks. So one question to you, that Juhi, and we can say to Meenakshi, that at what point of time you think that it is a right time for screening, and you offer screening for everyone, or you still pick up that history taking is important to select real high risk cases for the GDM or the diabetes present before pregnancy? So Juhi,
shall I speak or Dr. Meenakshi? Whosoever,
Juhi,
right?
please carry on.
Juhi.
Shall I speak, ma'am?
Yes, yes,
Okay,
Juhi,
okay.
yes.
Yes, ma'am. A very good evening to one and all. I would just like to say that we are offering universal screening to all the pregnant women, because since long WHO has already recommended that, and that you have to universally screen, especially in Southeast Asia region, and that too in India, since now India is a diabetic capital of the world, as we see. And secondly, whenever patient comes to you, so many a times in our OPDs, in our government setup, we see that patient don't come when they are pregnant or when they are just UPT positive. They come to you when they perceive fetal movement. That is around 20 weeks. So if at all patient comes to you at that gestation, offer her screening. So screening is mandatory on her first visit.
Yes. Yes,
And
go
second
ahead,
thing,
Juhi. Yes.
and ma'am, second thing which you said, that is history is important. Yes, history is always an art and it should be always taken, though it may not be related to screening. But of course, if further management we need to do in this pregnant women, if she turns out to be impaired glucose or she has that propensity, it is better to have that history, because it will help us to counsel the patient regarding her diet, regarding her consequences. Because what I have seen in my OPDs, the moment you said that you may have diabetes, they just put themselves aback. No, I don't have diabetes. So counseling is one very important thing which you have to do in this patient.
So one thing is a very important message from, yes, Meenakshi, yes.
I would
Yes,
just like
Meenakshi,
to
please.
add upon that we are doing universal screening, as Dr. Juhi said, and it is at first visit. Whatever is the gestation of the patient, we do it at the first visit. We don't want to miss that opportunity, because we don't know whether she is going to come again or not. And as Dr. Piki said, that we are doing point of care. So we get the reports, that day
Within
only.
2 hours.
Yeah, within 2 hours. So we are not missing that opportunity that she comes back on another visit. And secondly, I'll just add that if the report is normal, then we will repeat it at 24 to 26 weeks. And if it is again normal and the patient belongs to high risk category, then we'll repeat again at 32 to 34 weeks.
So that is a very, very important point, actually, what Meenakshi has said, that universal screening. I think we have percolated this message to at least gynecologists of our country. But this is important, that the first trimester is like, which is the first visit we say in the first trimester, because when the first trimester blood sugar level are high, the management protocol is also a little bit different, and you have to repeat in 24 to 28 week. DIPSI also says, and every association, because that is the time which is actually the thing when the GDM develops. So this is very important, that you cannot miss, that I have done in first trimester and not missing that 24 to 28 week crucial time. So a very important message. And of course, any high risk situation, we have to confirm in the third trimester. And Vicky, what you say, that should we make a protocol considering that high rise of obesity and everything, that in third trimester, 30 to 34 week, we do again blood sugar. So Vicky, what's your opinion about it?
Ma'am, I think that is a very wise suggestion, because what you have said is correct, that it should be done in the first visit. But sometimes, as you know, in our medical colleges and in the peripheries, the patients are coming at the time of delivery. So we should not miss that opportunity and do it in the third trimester or even at the time of labor. How it will help is because this woman now has to be counseled that in the next pregnancy, she may again have GDM and later on develop diabetes. So what DIPSI has said originally, that it should be done in the first visit, it should be done at 24 to 28. And as you are saying correctly, with the pandemic of obesity coming and high risk pregnancies, patients conceiving at a later age, and the junk food that they are eating, it is wiser to do it at 32 weeks also. So 3 times it can be done, and it is so cheap, ma'am. IAD PSG done once or DIPSI done in all 3 trimesters, it still comes out to be cheaper than IAD PSG.
It is one of the very important and what you say doable when we can do growth scan, when we can do color
Yes.
Doppler. It is no way that we miss, and we really find the third trimester diabetes developing with the negative screening at first and second trimester.
Nearly 1/3 of the patients are coming positive
Yes.
in the 3rd trimester, ma'am.
Yes.
So we should not miss the opportunity.
So the second question again, a lot of thing has been already said. The DIPSI chat with Picky says that they are doing wonderfully at Lady Harding with 400 OPDs. Still, when we do the real panel, there is a lot of confusion and people are saying that no, we do only OGTT, we only do the 75 gram, and many says that we believe in HB1AC glycosylated hemoglobin. So to say Juhi and Meenakshi or anybody, Dr. Padma can take it, that what's your opinion that what test you are doing, and are you offering different screening tests to different type of people? So in corporate sector, they say always we do OGTT, we do the 6 sample, 4 sample. So what's your takeaway on that?
Dr. Juhi and Dr. Meenakshi can continue to take this.
Yes.
Hello.
So, madam, my take is we have been practicing the 75 gram glucose challenge test DIPSI guidelines since long, and HbA1c, as far as HbA1c is concerned, that HbA1c on first visit it's okay, but otherwise trimester wise there is no role of HbA1c in pregnancy. First visit, suppose the patient is overtly diabetic and you don't know about the diabetic status of the women, because you never know, our women are harboring diabetes and they don't know about it. So the moment they come to you, you can do HbA1c so that you may come to know whether her what was the level of her glycemic control. So that way HbA1c is okay. And definitely for screening, 75 gram glucose challenge test, which is very feasible, comfortable, which we say that it should be irrespective of fasting state of the woman. So it is very comfortable for the women. And no need to do OGTT or 50 gram challenge test. I think 75 gram glucose has good sensitivity. It can pick many GDMs in our population.
So Juhi, we will like to clarify for the audience that why the patient says 2 hours postprandial, because they are all Googling. So why it is necessary to give the challenge test? And secondly, what we say, anybody differ and working in corporate sector, actually we talked of DIPSI, but really we see that they do OGTT, and why the OGTT is not feasible for a vast majority of the people. So one comment from you that like clarity why we need the challenge test, and only the 2-hour postprandial test can be confusing and sometimes missing the diagnosis.
Yeah. First thing is OGTT is a 2-step test, and definitely the women won't like that you withdraw blood 2 times in a day. So that is really very discomforting for the patient. Patient do not want कि मेरा 2 बार कोई blood ले. First thing. Second thing, we have to convince the patient that when you are a pregnant woman, the postprandial sugars are more important rather than a fasting or random sugar. So that you have to convince that in a pregnant population, you have to give a postprandial test, and that will give us a good idea about whether this particular woman who's undergoing the test may be GDM or not.
So this is very important that in screening for GDM, we need to give the challenge test. So it is not only the food, we have to give the challenge so that we don't miss, even after screening, that we miss the diagnosis of GDM. So one thing is important, that the 75 gram glucose challenge is important. HbA1c is not a screening method, especially in 2nd and 3rd trimester, because of all physiological changes, and this value actually does not tell us the right thing. So the blood sugar monitoring remains remains our screening and the testing protocol. And the next question is, what level of blood sugar in obstetrical population? Confirm 2 things. One is DDM and one is the frank diabetes. So Meenakshi, you can take away.
So as we are doing DIPSI, so the level, the 2-hour value more than 140 milligram per deciliter, we are taking as GDM. And if it is more than 200, then we label her as frank diabetes. So the cutoff is 140 and 200.
So great. And HbA1c, especially if she is in the first trimester, what is the value you consider that she is frank diabetic?
More than 6% we consider as the diabetics. And for HbA1c, we don't do them in antenatal patients. We consider HbA1c screening in the ones who are trying to conceive. So basically, we are doing it in our reproductive endocrinology or infertility clinics, where we need preconceptional counseling and optimization of blood sugars. There only we recommend HbA1c.
Can I just
Thank you
add
very
one
much.
thing?
Yes.
HbA1c by ADA 2024 says should be less than 6%, but ACOG and other guidelines say that 6.5% is
6.5, yes, 6.5.
And the important thing is that the patient should not get hypoglycemia. Just to get the levels lower, she should not be getting hypoglycemia. So if it's a pre-diabetes or overt diabetes, then even 7 is okay before she conceives. But 6.5 is the ideal. And if she can get less than 6, which is difficult in pre-diabetic patients, then it is the best. And one more thing, why glucose load is important. Dr. Sadhna made a very important point. See, we are all insulin resistant people in Asian community, and we are 11 times more prone to get diabetes. We have hyperinsulinemia. So when the patient eats some food, there is enough adequate insulin to absorb it and bring it to normal levels. But when we give an extra load of 75 grams or whatever, then the glucose levels becomes much higher, and it is difficult for the compromised pancreas of the Indians or the Asians to produce more insulin to bring it down. So this is the big stress test to check whether she has diabetes or not. For postprandial, we may get normal levels, but after glucose load, if she comes positive, then as Sir says, she's GDM. But when postprandial more than 110 we are getting, we are saying she is early gestational glucose intolerance. She is not GDM without the glucose load. So that is the funda of this.
As sir has already
excuse me,
pointed
ma'am.
out, Shreya sir also, na?
Yes, Ritu.
Yes, ma'am. What is your take on adding the fasting blood glucose level to DIPSI also? Because now the evidence is saying that if we are taking that fasting levels also into consideration, we may be picking up more patients, more GDM patients than if we are going only for that 2-hour postpartum glucose challenge test. What is your take on this?
What I think is that when we are looking at patients in our OPDs, it is very difficult. In fact, I did a survey in our OPD. There were hardly 4 or 5 patients who were fasting. And in pregnancy, when we have to go for our test, it is difficult to fast till 8, 9, 10 a.m. And these patients are pregnant, and we cannot afford to lose them. So why DIPSI test has become so important is that the funda is that we should not lose the patient just because she's not fasting.
No, ma'am,
Of
I'm
course,
not saying that.
fasting-
I'm not saying that. I'm not saying that we are following that DIPSI only. But the recent evidence says that if we add fasting, if at all it is feasible, then we may be able to pick up more patients with that test. That's
I
all.
think Ritu, there is 2 things. You can do even OGTT. It's fair enough. It is also a challenge test. But considering the wide range of situation that like everybody's OPD time is people are coming from far distance.
Yes,
So
ma'am, yes.
DIPSI test is a practical thing
DIPSI
with a very good
is-
efficacy. Otherwise, even if you do OGTT, it's fair. You have to screen. You have to screen for wider range. Yes.
Ritu, there are a lot of papers. If you see the FIGO guidelines on hyperglycemia, it very clearly shows. In fact, I was thinking of putting it up in this panel that the fasting levels in Indians and Asians is much lower. And
Much
it is
lower,
the
yes,
postprandial level, which is the pathognomic or the more diagnostic of GDM. So
Yes.
fasting से थोड़े ज़्यादा मिल सकते हैं. But we have done one study, ma'am. I'll just take 1 minute, in which we have compared Carpenter, Houston, and DIPSI. What we found was the patients who were having high fasting level also had high postprandial. So there were very few number of patients who had isolated fasting hyperglycemia. So cost effectivity,
Yeah.
labor intensive, and एक बंदा चाहिए who's taking out the blood So that way, this is
That
very
is
good.
not, yeah.
Dr. Picky, if I can add here, from a diabetologist perspective, see, the whole idea is you want to look at beta cell dysfunction because the compensatory hyperinsulin, the insulin secretion is going to be delayed. So that is why the likelihood that a patient has a impaired fasting but a normal postprandial is impossible. But the likelihood that the patient may have a normal fasting, but the moment you give a glucose challenge, the beta cell dysfunction will manifest itself and the postprandial will be deranged. So that is why no harm doing a fasting, but then making it mandatory is adding one extra test which is not going to add value to your diagnosis. Because so many times you will see that the fasting is normal but the postprandial is delayed. So the moment you do a 75-gram glucose challenge, immediately beta cell dysfunction will manifest.
It
So
will
that
pick
is
it
why
up.
no point of doing a fasting here.
Yeah.
Got it, ma'am.
And
Thank
what
you.
I was trying to say.
So next,
Actually,
you
madam,
can,
in
Picky,
pregnant
you
women,
can
there are lot many
share the slide.
physiological changes which occur.
Yeah. So another very important question, the problem which we are facing every day. Dr. Shalini, this question is for you. This is a lady, 28 years old with PCOS, and she has she has conceived on metformin therapy. She is obese, as you can see, BMI is 29. Mother is also diabetic and hypertensive. She comes at 8 weeks, 3 days. And when will you like to do test her for GDM or hyperglycemia in pregnancy?
This question has been answered earlier also, that immaterial of even all these risk factors, there are so many risk factors here which directly point to insulin resistance and a very high risk for GDM. Number 1, age. Number 2, PCOS here. Number 3, BMI. She's already obese. Number 4, family history. So all these definitely are high risk factors for GDM. So definitely the screening for GDM is mandatory for her, ideally preconception also. And then, yes, ideally preconception. And then at the first point in contact, the moment she comes, already she's a high risk case. Southeast Asian ethnicity itself is the number 1 risk factor for testing
All
for
are high
GDM.
risk.
So all Indian women are high risk. So even if these risk factors were not there, GDM screening has to be done. But any which ways, now that you see so much of insulin resistance in this woman because of PCOS, obesity, so definitely the testing has to be done at the first point in contact, because these women are the highest risk women who will convert to GDM eventually. So every trimester, if the first trimester it is negative, then second trimester, and then even in third trimester, this is exactly the index case who needs to be screened for GDM in every trimester.
And as we discussed earlier, Dr. Shalini, many of the infertility consultants are not doing blood sugar testing at all. So that is mandatory. That is why I put this infertility and PCOS case here, that we should be sensitized that whenever the woman is coming to us with PCOS, whether she's infertile or gynae OPD, AUB, we must take the opportunity to test her high BP and blood sugars. Another
Even I would like to put in a message here, even before an IVF. Many a times, I've had cases where the IVF has been done and then they've checked the blood sugar when the take-up is positive, and then they panic and then they send a reference. So I think even before going in for any kind of assisted pregnancy, it is mandatory. Most of the people are doing, but then yes, there are a few institutions where it is still missed. So I think it has to be done pre-conception and then at the first point in contact and then every trimester.
That is the most important point.
Ma'am, can I ask a question? This preconception before IVF and before IUI, should we do that 75-gram glucose test? Or should we
Yes,
do it?
ma'am.
Right.
Ma'am, see, in a non-pregnant woman, it has to be a complete 75-gram oral glucose tolerance test. That means a fasting followed by a 1 hour and a 2 hour value.
Right.
Non-pregnant, it has to be the typical 75-gram oral glucose tolerance test with 3 values.
Yeah.
2 values.
No.
Shalini, I think
No, we do fasting 1 hour and 2 hour.
We are doing 3 values. We are doing
One
3
thing
values.
I will say that
diet-based
every Shalini, I will like to say one thing for gynecologists. I think whenever the couple drops for any infertility, it is not only female. We are screening male and female both, and so many times we are detecting. So if
Absolutely,
you
ma'am.
find really referral, because I think, Monica, we all are screening for diabetes, the couple in the infertility, any sort
Most of the places it is
All
being done,
patients,
ma'am.
all patients, even in gynae,
yes.
ma'am, we need to test. Today only we had a stillbirth. The lady was 41-year-old, oocyte donor, IVF pregnancy, and her OGTT, her DIPSI test was 256, and she has an IUD, and we lose the baby. So it is criminal not to do a
Yes.
Madam,
Dr.
is there any possibility we can do HbA1c instead of the full OGT?
In non-pregnant patients, yes,
Yeah,
Dr.
yeah.
Monica.
Because
definitely.
But ma'am, the problem is even in non-pregnant, if she's anemic, if she's got hemoglobinopathies, there are so many places where HbA1c may be false high or false low. So simply making a diagnosis of diabetes based on an HbA1c may not really help you. So
Right.
that is why I think ideally any woman who comes to you for preconception care and counseling, a 75-gram oral glucose tolerance test is mandatory for her.
Yeah, that's a very good message, Dr.
I
Shalini.
think that's
Thank
very
you so
important.
much. Thank you so
If
much.
it is-
And Shalini, in our experience, we have seen the HbA1c normal. Before the HbA1c becomes abnormal, the patient would have gone for glucose abnormality.
Yes.
Absolutely, ma'am.
Absolutely. So, Dr. Shalini, would you like to discontinue metformin before testing?
Okay, now this is definitely the million-dollar question, and I think every gynae meeting, diabeto meeting, endocrine meeting, anything talking about pregnancy, we talk about metformin, yes or no. So, okay, pertaining to this case, she already has PCOS, and clearly all guidelines, including the ADA guidelines, say that if metformin has its benefits in terms of ovulation induction, it has an insulin sensitizing effect, it controls weight gain. So definitely metformin may be continued in this case, especially till the first trimester as per the American guidelines. But in India now, the DCGI also has given approval, and metformin can be safely continued all through pregnancy unless until there is a contraindication to metformin, or you are seeing reasons where you need to stop the metformin, or the dysglycemia goes up to such an extent that it is not well controlled, and then you need to add on insulin. So
Dr. Shalini,
yes,
wait. So I was asking you, before doing this DIPSI test or OGTT, should we stop metformin? We take your idea and recommendations later
see,
on.
ideally, when you doing a 75-gram OGTT to rule out pre-diabetes, there, yes, metformin should be stopped. You subject her to the test, and then you see the values, and then you decide. Since you're already putting her on metformin, 75-gram GTT value may not really be influenced much, especially the post-glucose values. The fasting may be influenced by metformin because metformin reduces hepatic endogenous glucose production. So there, the fasting may be a slightly low if she takes metformin the prior night before the GTT is done. So in that case, metformin on the night that she's going to do GTT should be stopped, and then she does the GTT the next day.
Dr. Sadhna, what is
yes, ma'am? So that is a question. Actually, metformin has got its a prolonged effect on the blood sugar level. So this is something that with metformin we may be missing. Like it may be having the normal blood sugar level, and if we want to discontinue in first trimester, so it will be a lot of like it is a really tricky thing, and like the withdrawal of metformin and like doing after this DIPSI test may give us the like a real picture about it. So it's a confusing thing, and Picky very trickily asked this question. So Picky, what's your opinion? I say,
what I think is we should not stop metformin, because whatever glucose control she is having with metformin, we may lose it if we stop it for 2 to 3 days.
No. All you need to do is stop it one night prior if you are going to do a fasting. If you are just doing a DIPSI test, you need not stop.
Dr. Shalini, just a minute. If we are going to detect, we are using it for EGGI, early glucose intolerance, and if with metformin we are able to attain 120 ka postprandial and 95 fasting, then it is okay. What we want is that what Sir says, and what I understand is that the postprandial and the fasting or the pre-meal need to be in the normal range. That is the purpose. And we have to follow this patient as was discussed earlier. And I don't think metformin should be stopped for this
Vicky,
patient.
like what you do for your primordial prevention, when you're putting them and metformin, you're following them with the first trimester, second and third.
We are doing with metformin. So same we can do for this. That is what I'm saying, Dr. Bhaftani.
Yeah.
For the study that we had just presented, we have started metformin at 8 weeks. And in spite of that, we are doing a DIPSI test in the first trimester, second trimester, and third trimester. And we are picking up patients who are having GDM. So I believe that the fundamental is the same. We should not stop metformin when her blood glucose levels have been controlled on this. And we can continue keeping a strict watch on her. Because she's very likely to develop diabetes, GDM soon, with the kind of high risk factors as we can see in the history. So I don't think.
And we will, one question again, it emerges that if with metformin label, what Shalini and Vicky says, if label are okay, then it's okay. But with metformin, if label is around, say, 150, 156, 148. So what will be your takeaway? Converting to insulin, doing
Absolutely, ma'am.
OGTT, what is there?
Absolutely,
Yes.
ma'am. The moment she is over the over our level for control, that means if it is more than 120 with metformin, then definitely insulin has to be given, because early pregnancy we need very tight glycemic control for organogenesis to happen properly. You don't want congenital anomalies coming in at this point. So definitely very tight glycemic control is required, especially in the early pregnancy. So the moment you see more than 120 with metformin, it has to be insulin immediately.
Shalini, if it is just little away, that is, if it's just more than 120, why can't we increase the dose of metformin?
No, I mean,
There are
I am
two options.
I'm assuming if it is maximum dose of metformin.
No. This is just 500 milligram, na, Dr. Shalini?
Okay. So then you can make it, then you can definitely go up on the maximum tolerable dose of metformin in pregnancy, but still if it is not under control, definitely insulin.
Yes. So, Dr. Meenakshi, will you take this question? How will you work up with this patient if the DIPSI value comes out to be 214? And then you please tell us what are the glycemic targets in pregnancy. It has already been discussed.
So if Dr. Binu Kushwaha is also joined.
Okay, great. So Dr. Binu can take this question if you want. Meenakshi, tum bol do.
Yeah. If we have value of 214, so clearly we need to now have a 7-point blood sugar profile of this patient. So we'll go for fasting and pre and post meals to our post meals values, and depending upon that we will do insulin adjustment. So we'll prefer regular insulin, short acting and intermediate or long acting insulin, and accordingly we can start up with the insulin. And for the workup, we'll get the systemic investigations also.
Yes.
Like we'll get her renal function test done.
Yes. Meenakshi, carry on.
And fundus examination to look for any retinopathy. And for nephropathies, we should look for and do renal function test and UPCR, urine protein creatinine ratios. So we'll do these investigations. And of course, antepartum fetal surveillance will go along with it. And in the 7-point values, if our insulin is able to cover up the values and we get the glycemic control, that is fasting should be below 95 milligram per deciliter, and 1 hour and 2 hour values 140 and 120 milligram per deciliter. So if we are able to achieve this, we can ask her to follow up with her blood sugar profiles every 3 to 4 days or weekly if we are following in OPDs, and she can do it in a staggered way also with the pairing up.
Meenakshi will come to that later. Ma'am, I just want to take everybody's opinion. Are you doing 1 hour or 2 hour testing for postprandial?
2 hour, ma'am.
2 hour. So I think there should be a consensus, because the endocrinologists sometimes talk about 1 hour, but there is a consensus that we should do it only at 2 hours.
2 hours. 2 hours is fair enough. So another very important ground reality question. When the whole world and the commerce is now focusing on the nutrition therapy. So why we are putting this, then when you say that it is a 150, so whether you take insulin, whether metformin, the diet remains the cornerstone, diet and exercise, and more so the diet. So we will like to have opinion. Reenu is there, like from Riva, from different specialty, from Delhi and from Bhopal, the panel is there. First of all, do you have a clear idea what to say in a clear language? Do you have dietitian in your setting, and are you feeling comfortable? You are feeling quite confident and comfortable that you can give good dietary advice? Because what we say when we say that this thing, Google, net, and even our educational material, it is broccoli. In North India, it is idli, dosa, and yes, and it is actually. Sometimes we say that what the person is standing before it, we know what they are eating and how to tailor. So it is about connecting doctor and people by and large. My question: do you have dietitian? Are you happy with the dietitian? Because sometimes dietitian also makes the thing very complicated, and how you are competent and how you solve. So your message that how you solve in your clinical practice, so that everybody can utilize your idea.
Ma'am, we don't have a dietitian.
Slide share.
So
so you are comfortable. So that's the thing. So how do you like? आप बहुत simply कैसे बताते हैं अपने?
Ma'am, we have dietitian at our place also. It is the management is also always a multidisciplinary. So we always try to involve dietitian, endocrinologist in the management of GDM or pre-gestational diabetes. But definitely we should know, because the patient is with us. We have to counsel the patient about the nutrition, about the role of exercise. So in simple language हम उसको यही बताते हैं, आपको green vegetables ज़्यादा लेना है, avoid the fatty food, junk food. आपकी थाली में, जैसे हम हर पेशेंट को बताने की कोशिश करते हैं कि आपकी थाली में आधा प्लेट should be vegetables and fruits, 1/4 should be cereals, and 1/4 should be your protein and dairy products. And she has to take 3 major meals and 2 to 3 snacks. Avoid, because ज़्यादा इकट्ठे नहीं खाना है. ब्रेकफास्ट में आपको स्प्लिट करना है उसको. So the basic thing we try to counsel with the charts, because we also have a room, DIPSI room, so we try to tell the patient, inform the patient with the diagrams about the importance of nutrition and the exercise also. That is moderate, mild to moderate. आपको walk करना है 30 minutes a day, at least 5 times a week. So it is very important.
Madam, as you said, for everybody to have dietitian, we all can follow the same what you said: split meals and more proteins, less carbs, less fat, like that.
Madam, what we can, what I feel, what we do. Ma'am, can I speak, ma'am?
Yes, please.
Madam, what we do in our clinical practice, in my clinical practices, what I do is first I ask them what is their food and what is their lifestyle. I first ask them, what do you eat first? How do you sleep? What is your pattern? Whether you are working, non-working, whatever, everything. Then once they say about what they do, what they eat, then I put a bit modification that if you are fond of eating rice, okay, eat rice, but in moderation. So that is how you counsel them. So their own diet, and you make little modification in their own diet, just add on something and ask them to make small meals. I mean, frequent small meals, so that glycemic peaks can be avoided, and add some of the food stuff which they are not actually taking, but feasible to take, and they're ready to accept. I just add those meals, and it and definitely the control does come. And what I feel is dietitian, many a times they add many fancy things which patients do not accept.
Yes, thank you. I think Taru and Juhi has done excellent thing. Small frequent meals, ask asking what their life, what is their financial status, what are their habit, and a little bit change. And our women are fasting 2 or 3 things which we have found. They take meal around 11-12 when the children have sent to school and the husband has gone to work, and that they have to have कुछ practical चीजें कि आप अपने कमरे में कुछ स्नैक्स रखिए. आप ये मत सोचिए कि सब लोग खाना खा लेंगे, आप काजू बादाम रखिए, आप कुछ भी रखिए जिससे कि आप खा लें. आपको इतने बजे So this is थाली जो होनी चाहिए डेयरी प्रोडक्ट से, लीफी वेजिटेबल से, दाल से और रोटी से. और अगर आप 2 फुल्का खाते हैं तो अगर यू आर फॉन्ड ऑफ राइस, आप 1 फुल्का खाइए और थोड़ा सा चावल खाइए. आप मीठा लेना है तो हम उनको जैसे स्लो लाइक ए संदेश और समथिंग जो कि लो फैट है उसका चॉइस दे सकते हैं. सो माय वन कमेंट, डाइटिशियन आर वेरी गुड, दे आर आवर पार्टनर्स, बट समटाइम they make the thing very very complicated and a little bit, especially in pregnancy, ये भी नहीं खाना है, वो भी नहीं खाना है. So one thing what we say, खाना क्या है ये बताइए, नहीं खाना है उसको थोड़ा कम करिए. So this should be friendly and we should be aware of our people that what, क्योंकि सत्तू खाते हैं लोग. We always have a जो मेरा डॉक्टर शशैया और पिकी तुमसे कहना है, हर पेपर में मेडिटेरेनियन डाइट को इतना उछालते हैं, जैसे कि फ्रेंच का जो शैंपेन है, एक गांव का विस्की है, उन्होंने उसको इतना ग्लोबल स्टैंडर्ड बता दिया. टू मी द इंडियन डाइट इज द वन ऑफ द बेस्ट एंड बैलेंस्ड डाइट, and we must take at the Dipsy and the Foxy and every label that we have to make that confidence in our Indian diet, which is very good for the diabetes.
Very true, very true.
Ma'am, we have the Dipsy plate which is there and it was distributed also. I don't know if it came to the gynae community. We have the Dipsy plate.
We have the Ministry of Health and Family Welfare.
Yes.
Also, which is the same as the Dipsy plate. And I think it is a very, very useful and a practical thing if we put the picture and just show to the patient कि ये खाना है और ये नहीं खाना है, ये थोड़ा कम खाना है. And if she's taking rice, add more of dal in it. Portion size should be decreased. Complex carbohydrates क्या है, that should be enumerated to the patient rather than telling her 2050 kilocalories.
Yes.
Yeah, this is not what even my PGs and even ourselves, we don't understand. It is better to give
madam, one more thing I would like to add. One more thing, what happens, even our women who are housewives, they are not aware about the nutritional value, what they use themselves use in their kitchen. Like methi dana or dalchini. You can always tell them about all these
our food is the best, and gaon ka khana, it is all coming back, ma'am. Millets are now so expensive. Jave, poha, all these things are the best things, and we are going after West and junk food and useless things. So I think
thank you. Yes. Next, begin. हम लोग का बहुत टाइम, like I think we have few minutes left.
हाँ, चलिए मैम आगे चलते हैं. मॉनिटरिंग मैम कर ली ना, मीनाक्षी was telling.
हाँ, मॉनिटरिंग हो गया, हाँ हो गया.
ठीक है.
How? Yes. So
this
I think it has also been done. Yes.
So in the first,
anybody for comment on glyburide? Any comment on glyburide as a oral hypoglycemic? So we have talked a lot. Yes.
Ma'am, we don't use glyburide and we take it as a contraindication because studies have shown glyburide से neonatal hypoglycemia भी बढ़ता है. Plus, as it is, patients usually they need insulin once the glycemic control slips, you know. So sulfonylureas, including glyburide, none of our guidelines recommend using glyburide. So it has to be insulin plus minus metformin.
So clear message, glyburide is inferior to insulin as well as metformin and not to be used. So
not to be used.
So the problem is neonatal hypoglycemia and macrosomia is more, and 30 to 50% patients will not get controlled only on
they will need insulin.
So ACOG says that you should not use glyburide, and I think none of us is using glyburide for pregnant patients. So Dr. Shalini, in short, you told us the advantages of metformin. Will you tell us the concerns and the safety profile of metformin?
Two most important concerns we need to understand is risk of prematurity and small for gestational age. Few studies, these signals have emerged with metformin. So the contraindication to metformin, suppose you've already put the patient on metformin and scans show that the infant is going small for gestational age, or there is an indication of placental insufficiency. or if IUGR, if it is going towards IUGR, you should immediately stop metformin. So prematurity, small for gestational age, placental insufficiency, preeclampsia, IUGR, these are some contraindications where metformin should be immediately stopped. Otherwise, you can safely continue if the mother is tolerating it.
And another very important and good points made. Another thing is that whenever
Shalini,
the
if I am correct, even in twins.
In twins, not necessarily that twins.
Twin pregnancy, ma'am, only you are seeing one of the twins going towards IUGR, definitely metformin should be stopped.
So
Any
whenever
MGR
there is a vasculopathy, yes,
Any vasculopathy, high risk pregnancy, there you should stop.
See,
And
whenever
also there are concerns regarding that long-term effects on the baby also.
Yes,
Yeah.
there are studies which have shown that mothers who were given metformin in pregnancy, their children, they had more of adiposity signals.
They
So
become more
their
weak.
waist height circumference, their abdominal circumference, tricep skin fold, all of these were more. So we have two lines of studies. One line of studies have shown follow-ups even to 9 years and 11 years, where these children, the BMI Z scores were on the higher side. Due to intrauterine exposure to metformin. So that is another one signal where we do not have clarity. Recently, Dr. Yajni group, they came out with a study which did not show this in the Indian children, but the male child compared to the female child again had high normal obesity indices. So that is again a long-term thing that needs to still be seen. We do not have clarity. But yes, the adiposity signal is there.
But
now the good
Saptaji Bhattacharya from Delhi, he has followed them up to 11 years and has shown
Yes.
no difference between insulin.
Yeah,
and
this is Dr. Yajnik and the Bhattacharya group.
So now we know that most of the guidelines were recommending metformin as second line. But now the good thing is that the Drug Controller General of India, that is the regulatory body in India, has recommended that metformin can be used safely in pregnancy. And another very, very strict body, that is the European Union. This is different from NICE guidelines. These are the regulatory bodies which are the law of the country. They have in 2022, based on this study which I was showing, this is a huge study. As you can see, 3,000, 5,800, nearly 10,000 patients. This was published in BMJ Open Diabetes Research and Care. And they came out with the recommendations that metformin can be used from conception till delivery. So as you can see, insulin, of course, is the first line, but metformin is equally good and can be used as a first line by NICE guidelines, but it should be told to the patients that it can cross the placenta and the concentration of the drug in the baby is also very high and long time safety is not established. So we can easily, safely use it. And just 1 second, Dr. Shalini, just will you tell us about the rapid insulin, the regular insulins and the long acting, just name and what is the advantage of analog?
So we have three kinds of insulins. Rapid acting insulin is the bolus insulin, which starts acting immediately when you inject, and it takes care of the postprandial spike that comes. So usually women who have pre-gestational diabetes or even GDM in the last trimester, where it is only the post-meal sugars that are going up, their rapid acting insulin before the meal works best to bring the postprandial less than 120. Then you have intermediate acting insulin, which is kind of NPH insulin or Insulatard that we used to use in medical college days. But nowadays, normally we are not
still using, Dr. Shalini.
Okay. So again, intermediate acting insulin is the mixed-start kind of an insulin where you have 30% of the rapid acting and you have the 70% fraction, which is the longer intermediate acting for the next 12 hours. So these are to be given twice a day, one before breakfast, one before dinner. The problem with these is the post-lunch spike sometimes may not be controlled, and that is where you need to add a bolus of the rapid-acting insulin before lunch to get all the three meals under control. Then you have the basal insulins, which is the long-acting insulins, which work for 24 hours. And now we have ultra-long basal also, which is the degludec insulin, which works almost 36 hours. So basically for any woman who has type 1 diabetes or type 2 diabetes, that means pre-gestational diabetes, we prefer putting them on 3 shots of rapid acting plus 1 shot of basal insulin, which is called the basal bolus regime. So with the pre-meal insulins, we are able to get all the 3 post-meal glucose levels on target. And with the basal insulin, we can regulate the fasting glucose. So that's the best regime. Otherwise, you can use for the GDM women, you can use either the intermediate, that means the mixed-start insulin, or the rapid acting based on the glucose profiles that she has. And all these insulins have been found safe in pregnancy, even amongst the newer, conventional insulins, Ectrapid, human insulin, mixed-start, all are safe in pregnancy. Rapid acting also, Aspart insulin and Lispro insulin are indicated in pregnancy. Glulisine insulin is one insulin where we do not have too much of data in pregnancy, so not yet cleared in pregnancy.
Only these ones are cleared for use in pregnancy.
Yes.
But if the patient is already controlled on glargine, can be continued.
Can be continued on glargine, and Degludec also can be continued.
Degludec is now approved.
So one question.
Safe.
One question to gynecologist, like how many of you are comfortable with giving insulin on your own, or for this you really refer to endocrinologist or physician? So to gynecologists, are you always able to summarize which insulin, what's your real practice? Juhi,
I used to refer the patient to endocrinologist to give insulin.
Madam, when I was a student,
so because medical legally, yes. बताओ जूही बिल्कुल
my sir, my teacher, he was in Ahmedabad. He always used to never used to refer the patient to endocrinologist, and that was the best method what I felt. But since now I am in practice, and since long we have been referring all our patients to endocrinologist, and many a times what we find is, whenever you refer the patient to endocrinologist, either they give very strict control of glucose, or they give, there is lot of spikes of hyperglycemia. So what I feel is, you can manage 2 to 4 units of insulin on your own and tailor that accordingly on top of endocrinologist as well.
We have to monitor the blood
one
glucose
thing
levels.
Sometimes,
Endocrinologist.
So one thing is, it is the time when we physician or endocrinologist come to you. So one thing is the medical legal angle also, because you know that so many suddenly it is that may diabetic ketosis, hypoglycemia. So it's better that we take the help in newer insulin are coming. So sometimes difficult to
the voice is breaking, ma'am.
On your
voice is breaking. We are doing ourselves the insulin titration. We are doing ourselves, but whenever we have problem, we do not feel shy to go to our endocrinologist or physicians, medicine people to help us in that. I think if you are comfortable, it is okay. Otherwise, the management of a hyperglycemia in pregnancy patient has to be along with a dietitian and a physician or an endocrinologist. We should work up and do the best for the patient. It is not important that you try to manage yourself if you are not confident. So that is the only thing. So what are the other complications which are associated in GDM, which we need to be careful about? So Dr. Binu, please answer, because Dr. Juhi and Meenakshi have been answering.
Yes, ma'am. Yes, ma'am. Good evening, ma'am. Sorry for joining late, first of all. I hope I'm audible, ma'am.
Yes, you are audible.
Yes. So ma'am, it is the most important other disorder is hypertensive disorder in pregnancy, which we should be taking care of and monitoring her BP in every visit, and should be counseling her also. And then thyroid disorders also, actually.
Yes.
She may be prone to have that even prior to pregnancy, but she may not have been checked for that. So we should be checking it in each trimester, I would say. Generally, we do it only once, but here we should be checking it each trimester. So I think these two are the most important ones. And then other infections, urinary infections, we should every time ask her that is she having any features of urinary infection or the candidal infections, because they may further cause preterm labor also. So preterm labor may be associated with diabetes per se also, and then because of the infections also.
Very right.
So those signs and symptoms should also be looked for.
Correct.
So,
So
you know, in this, because it is autoimmune, my voice is audible now.
Yes, ma'am.
Yes,
Am I
ma'am.
audible?
Yes, ma'am.
So it is a thyroid disorder, which is autoimmune disorder, and infection very, very important. Anemia always, and hypertension, and also always preeclampsia to be ruled out.
Yes, ma'am.
You
Ma'am, I
will
have
say
an
it is
emergency.
autoimmune
May
disorder.
I-
You, acha. Do you consider the TPO antibody titer in these patients? It's despite the normal thyroid level from the very first instance, or simple TSH screening, what we do in other patients?
Generally, simple TSH, ma'am, if it is associated with like BOH or some abortions or something like that, then definitely or she has conceived after taking treatment for infertility and it has not been done earlier. So I think if there is another associated factor is present, then only antibody thing is required. Otherwise, not
This
only
is,
TSH.
so one important click, which whatever you individualize the thing, because as South Asian, we are prone to autoimmune thyroid disorder also very much, and both are autoimmune disorders. So this is one point, and they both can have the bad obstacle history. So individualize when you want to do the antibody titer. So yes, fetal surveillance and how you do the fetal surveillance, anything different from the
Normal.
other low risk patient who is not having GDM, anything different?
I think, ma'am, especially the recent ones which have come in picture during the third trimester to rule out fetal macrosomia. First thing is, if she is already type 1 diabetes or pre-gestational diabetics, then she is prone to have FGR also. From that perspective also, we should be monitoring her. But if she is a newly diagnosed GDM, then it is the concern of macrosomia, which is of importance for us. Then these third trimester parameters comes into play. I mean, then that is important to get a real picture about the fetal weight. So I think that's it.
Two things actually we will say, which is the like a catch point. One is yes, aneuploidy, leave it, we are doing anyway. Fetal echo, which is sometimes which can be important. And secondly, like growth scan, now say everybody should have the growth scan around 34 week or 32 weeks. So you said about macrosomia, but the combo of GDM and growth restriction is a more monstrous one. It is much more so if the fetal biometry is okay, do you perform the regular growth scan and the color Doppler studies, which the sometimes patients are demanding from us? So what is the science behind it? Color Doppler when it is only associated with vasculopathy or IUGR or otherwise not.
Right.
So what's your takeaway? And the fetal
Even this echocardiography is
fetal
overused,
echo,
ma'am.
routine
This,
fetal echo
yes, ma'am.
GDM.
Fetal echocardiography is also overused even in those patients who have been diagnosed later on. I mean, earlier the profile was normal and later on it came out to be on higher side. They say the fetal cardiography is to be done. I think the indications are very specific for that. And same for the FGR role of the
Doppler
Doppler.
study.
Yes, ma'am. Yes, ma'am. So if she's a type 1 diabetic or pre-gestational diabetic, then yes, there may be a role, or there are features of FGR on examination or ultrasound, then only we should be going for Doppler. Because nowadays I'm seeing that in every diabetic patient, they are advising, even if it is only on slightly higher side, the glucose levels, then also they are advising Doppler. So that should not be a practice.
There is no role of Doppler because the flow is not compromised in
optimizing.
It is just chronic
the
unnecessary waste of resources.
Yes, ma'am.
A little waste of money and a lot of tension about it, and we don't know. And the one thing is important, that blood sugar monitoring remains very important, because no fetal surveillance, even if we do color Doppler, diabetes has a different pathophysiology and that we unexpected. So this is very important. The blood sugar level, the blood pressure level, this is very important that we it. And the fetal move. The fetal echo, it is a plus minus.
Your voice is again not audible. Hello, ma'am.
I think there's some problem with sound.
Yeah. So I think we need to wind up. What is the timing of delivery for a woman who is controlled, GDM controlled on medical nutrition therapy? Anyone can take that question. Dr. Sunita, Dr. Binu, Dr. Meenakshi, anybody. We can quickly discuss on MNT and on pharmacotherapy. What should be the ideal time of delivery?
And the timing of delivery, it depends upon the basically on the glycemic control, fetal well-being, and any comorbidities associated. And in case of that, if the patient is well controlled on MNT only, I think in any the delivery is not indicated prior to 39 weeks. It's not indicated. As per various guidelines, they say that we can go till 40+6 also. But as in our Indian setup, the babies they age earlier, so we consider delivering them between 38 to 39 weeks as well. And also the patients who are controlled on metformin or insulin, who are well controlled on these medications, then the various other guidelines, they say that delivery can be conducted between 39 to 39+6, but we want to deliver in Indian setup, we deliver them around 38 weeks only. But in case of the poorly controlled GDM and pre-gestational diabetes, we have to individualize the treatment also. And the delivery can be conducted at any time between 37 to 38+6 weeks, may be justified. And also, if there are, if there is poor control of the glycemic, this blood sugar levels in case of the hospitalized patients, or if the fetal testing is abnormal or any associated comorbidities are there, then we can go for delivery even from 34 weeks onwards, as and when indicated. So that's all I think. But considering that in the Indian setup, we go for a smaller gestational age, that is, we would like to deliver between 38 to 39 weeks if everything is fine.
Very well said. I think you have covered all the points. Anybody else wants to make any other comment, or anybody differs in their practice? Anybody is trying to take the patient till 40, 41 weeks? Any GDM patient?
Not beyond 40, not
Yeah,
at all.
we
Definitely
don't
not.
want to take them. Yeah.
Should, even if she's controlled, it is good to start inducing her at 39 completed weeks. Yes.
39, yeah.
Ma'am, Dr. Basu, ma'am, if you are there, we would like to have your...
Yes, I'm still there. I was listening with interest. And since you people had said it was a very, very informative as well, interesting discussion. And I didn't speak in between because I thought there are so many questions to be covered. And if I start speaking in between, then we'll never finish all the panel.
That's
so
what
I
you
thought
are.
the panel should go on.
Okay. Yes, ma'am.
But I've been there all throughout. And
Okay.
I was able to hear, apart from, a few misses here and there. And I think by and large, everything has been covered. Everybody is, coherent and aware. Probably most of us are following similar practices. So there's not a great deal of difference. However, one thing which was a point which was made that pre-conceptual counseling, they should all have their HbA1c and blood sugar screening, which is not being done. And that is very, very important. In fact, I would take it a little earlier. You have these young girls who come to you with PCOS. And we quite often at random start them on metformin or, whatever treatment, the other things we did. We did a study, a small pilot study, and we did a GTT, 3-hour GTT with 100 grams on all these girls. And believe me, many of them had impaired glucose tolerance, some of them with blood sugars 1 or 2 hours as high as 200. So it is easier. We start them young because the moment we, not only when they are coming to us for infertility treatment, even younger when they are still complaining of PCOS, and we'll be picking up a great number. So if the counseling starts then it will be followed up more diligently, hopefully later on, despite the lure of burgers and pizzas and everything, but we need to explain to them. Then I think another point which was discussed was screening. When should it be done? We do it at the first visit anyway. For pre-conceptual counseling, and of course those who come for the first visit, regardless of what time of the gestation they come. Usually in our hospital, in corporate hospitals, the moment they find a pregnancy test is positive, they'll turn up, unless their in-laws have stopped them from going to the hospital or something like that. When they come, we do an HbA1c for all, and we do a random blood sugar because they are there. If they are saying, okay, we can't take leave every day, can we get the test done? We said, okay, go ahead, do the test. What is interesting is that if we found HbA1c less than 5.5, not many of them would develop impaired glucose tolerance or GDM. But there was a very, very small cohort of patients who, even though their HbA1c was 5.1, we found that they developed GDM around 28-30 weeks. So there is a role for, getting the blood sugars postprandial or fasting checked. Now, when
Yes.
we talk about, how often we should check and what is the timing, I don't know what everybody thinks, and I would like everybody's input on that. That I tell them that when do you actually monitor your blood sugar? Is it when you finish eating, or is it when you look at the watch when you start eating? Because different people, they take a long time to eat, and then some are quick eaters, etc. And I find that if they start, there is a definite point. It's just something like LMP. We don't look at when it ends. We look at when it starts for everything that we do. So if they look at the time when they start eating and then monitor the blood sugars 1.5 to 2 hours, we find we get a better glycemic control, and patients are also becoming more and more aware. So which brings us to the topic of self-monitoring. That is a very, very important thing that we need. Dr. Juhi also made a very valid point about, finding their lifestyle and, what they do, what time they eat, etc. I think that is very important. We need to follow that up because we have found that fasting blood sugars are higher in those patients who eat late, stay up watching TV, sleep late, and then when they say to check their fasting blood sugars, they are on the higher side. So we need to counsel them that eat a little earlier rather than too late. So we have to modify their lifestyle from that point of view. Then regarding PCOS on metformin, should we stop metformin before doing the GTT? It's a moot question. Some will say yes, we stop it. Some will say because it has a delayed, effect. So I don't know whether stopping it just the night before will actually give us a true picture or not. But I do think that monitoring them, self-monitoring to see what their blood sugars are doing, even with that, what
Yes.
levels they
But
are taking. So
right.
monitoring would be very, very important in that case. And I think HbA1c, we can do it as out of interest, but it's an expensive test. And probably when you have an OPD of 400, I think we have to modify our practices and things depending upon the population and the people we are dealing with. Because we cannot expect everybody to be having an HbA1c, etc., in such a busy OPD. So we
Yes,
need
ma'am.
to people counsel them and tell them about the blood sugars. We must push the theory of preconceptual counseling as far as possible in whichever way we can, so that they are tuned into what are the problems that can occur. As I tell them when they come to us that, if the reports are abnormal, I said ki the foundation is set. Now we will only build on whatever foundation is there and try to make the best of it. That's all we can do. And then another thing about the dietitians, we must be very careful that we look at dietitians and those who are experienced in managing patients with diabetes. Usually people will employ people who have just graduated, and just because the tag dietitian is there doesn't mean they understand everything. And I have had, these youngsters, some of them, you send them to the dietitian and they come back with breakfast mein bola hai kela aur doodh lene ke liye, aur isme, I mean, they had no understanding of what they are talking about. So whenever you send them to a dietitian, please make sure कि एक बार खुद भी नजर डाल लें कि ये dietitian क्या समझा रही है.
Very
और
right.
let us counsel the dietitian later on कि भाई देखो ये सब चीजें नहीं, फिर से इसको देख लो, ऐसे करके तो गड़बड़ी हो जाएगी. Then another thing is कि whether we should manage it on our own or whether we should refer. Again, this has two aspects. If we don't manage them at all, then obviously our students will also never learn anything, because learning practical things is as important as, just reading it from theory. However, the medical legal issues do crop in. And I learned this very early on in my early days when I went to the UK. There was this patient who had fever, high fever, and I got some tests done. Anyway, to cut a long story short, I prescribed anti-malarials. And the next day when the consultant said, which physician has seen them? And everybody looking at each other, no physician has seen them. So then how did she get an anti-malarial? And he said, Dr. Basu prescribed anti-malarial too. I still remember he put both his hands on my shoulders and she said, Dr. Basu, I have no doubt on your competence of treating malaria, but for medical legal issues, please, we would like to hear to refer them to a physician. So that is a lesson which has stayed in my mind. And I do think that it's worthwhile that you can do a joint consultative kind of management where the students can also learn. We have our input. And at the same time, the physicians are there to manage and everything, because in a busy OPD, in a busy obs and gynae practice, you may not have the time or the energy to closely follow up such patients. And we really don't want that somebody has been given a higher dose of insulin and goes into a hyperglycemia, which can be really fatal at times. So I think it is worthwhile to have the physicians on board, so that are managed, in a joint way, and we take it on from there. But I think all these points have already been covered. Another point.
When do you deliver your patient? That was my very important question. In a private setup, when do you terminate pregnancy for these patients?
If the blood sugar has been excellent throughout the pregnancy, we wait until 40 weeks.
Okay. And how you are following up after for biophysical, or what are the tests you are doing? Because none of the tests.
All our patients in our corporate, we get our, the routine and screening tests up to the 20 weeks of pregnancy. The fetal echo was something which I was not doing as a routine, but I think we are also under a lot of pressure from the patients. मेरी उस फलानी पेशेंट का फीटल इको हुआ था, उसने कहा बहुत जरूरी है कराना, तो आप कई बार लाचार होकर के लिख देते हैं भैया कि कल को कुछ निकल आया देर से भी, तो कहीं ये नहीं बोले कि मेरा नहीं कराया आपने. तो पेशेंट्स की डिमांड पर भी हम लोगों को कई बार अपनी जो प्रैक्टिसेस कई बार मॉडिफाई करनी पड़ती हैं. However, I don't always like to get a fetal echo as a routine, but I do write it on occasion. We have very good ultrasonology. Also, this is another thing. A person must be properly trained in doing a fetal echo. A routine ultrasound done anywhere is not sufficient, because one who knows how to do a fetal echo, quite often in the level 2 anomaly scan, they can pick up most of the things. So it is important upon the expertise and the experience of the ultrasonologist. After that, we always do an ultrasound scan around 28 to 30 weeks when they're in the second trimester, where we screen them for everything. We do an LFT, KFT, we look at the ultrasound and the Doppler as a routine. So that's, as a routine, we do the Doppler. We find that we pick up patients who have, who may be turning, somebody says high resistance in the uterine artery, or they say looks normal, but the growth may be little pointers that is. Sometimes the ultrasonologists in our hospital, they ring us up and they say, this needs to be followed up. So if we do not pick them up at 28 weeks, we may miss them and catch them at a later stage. If we already find some changes at 28 weeks, then we can counsel the patient, we can give them steroid cover, etc. Be prepared that an early delivery may be required, not only for diabetes, but even as a routine. With diabetes, yes. But for diabetes also, we need to screen them again. And maybe we have another ultrasound around 34 weeks. So everything to,
It is indicated that every 3 to 4 weekly you can go for ultrasound. And also it's very important that you plot a growth chart. Clinical growth chart, and see the velocity, whether it is the same, it is going up or it is coming down. So you are able to FGR and macros. So
we have a patch system in our hospital.
And one question we can say, when you give for the potential preterm labor steroid, how many of us want
that's a good question.
The JDM steroid, or you say it's okay, you can get it at
those
home.
People, no.
Ma'am, we have a separate pura session on diabetic ketoacidosis, in which we are going to discuss the drugs, the precipitating factors, symptoms, and everything. So let us now wrap up.
So can I just make a brief point on this steroid point? On the steroid point, if patient is already diagnosed as GDM, or she is impaired glucose tolerance, then we advise them that it is better if you get admitted and monitored, because the blood sugar levels go up, and we do not want that to happen. Most of the patients in our hospitals, they agree. They are admitted for 24 to 48 hours. We monitor them and we tell them, continue your self-monitoring. If it goes beyond this or anything, please report to us. So our patients are turning quite good at self-monitoring, and they tell us, I missed my walk, so this is my blood sugar. I took this, then this is my blood sugar. So I think we need to empower the patients themselves, those who have GDM and impaired glucose tolerances.
But for our setup, we generally admit the patient because the blood sugars will start rising after 12 hours and they may stay high till 72 hours. And depending on how high the levels are going, we have to add up insulin in
Insulin, absolutely. This is what we do.
The consent has to be taken, a shared consent needs to be taken, telling them about the advantages and the risk of DKA, diabetic ketoacidosis, when they are being given steroids. So last question to Dr. Sunita or Dr. Taru. How will you counsel this woman in the postpartum period at the time of discharge?
At the time of discharge, we should counsel that the diabetes may continue throughout the life. So we have to do regular and postnatal checkups. We have to do regular blood sugar levels also in the postpartum period and throughout the life, because these patients are more prone for type 2 diabetes mellitus and this metabolic syndrome, and they may also have CVS problems. So they should be monitored frequently till the 6 weeks, and then after 6 weeks they should be monitored throughout the life.
So, ma'am, other than the routine postpartum care, which includes breastfeeding, contraception, we have to tell about the long-term consequences. The patient has a risk of GDM in the tune of 40% in the next pregnancy. Then she has chances of developing type 2 diabetes, 50% risk in the next 20 years, risk of metabolic syndrome, risk of cardiovascular complications. So we ask the patient to report at 6 weeks for a 75 gram OGTT, and then depending upon that, she may be normal, she may be pre-diabetes, or she may be diabetes. And if the patient profile is normal, then we ask the patient to come annually for examination.
Dr. Taru, contraception?
Contraception also, the preferred method is IUCDs as a very good method. Barrier method is good. And in patients who do not have evidence of end organ damage, in those patients we have to avoid the combined OC pills. Otherwise, all the other groups are category 2, MEC category 2 for these patients. So controlled sugars, we can offer them OC pills very well.
Otherwise, estrogen.
So one thing, Taru, I will say.
Yes, ma'am.
Yes,
ma'am.
No, just I say that whenever we say for PCOS, GDM, हमेशा सुनते हैं आपको कार्डियो, आपको हार्ट अटैक होगा, आपको ये होगा, वो होगा. I think the way of counseling is only that. Yes, I think don't make everybody die because of fear and anxiety.
No, ma'am. Awareness. Our aim is to tell them. We have to make them aware. We have not to make them afraid.
Because death is everybody coming. So it is something हम लोग क्योंकि पढ़ते हैं, बहुत पढ़ा लिखा है हमारे सिर पे रहता है. But as a medicine, as a healthcare, it is peace and happiness. Give them confidence. आपको हुआ है टेस्ट, आप इस तरह से खा.
So the importance of lifestyle modifications, diet, exercise, weight, proper weight gain, yoga, meditation, all these two things to be added in the lifestyle.
Right, the targets
very important is
blood sugar fasting, PP, and also it is important what you said, Dr. Taru, BP karana hai और BMI करना है, follow up में lipid profile करना है. Breastfeeding is another very important, which is going to bring down the blood sugars and reduce her weight. So postpartum discharge is very important time when we need to also counsel her कि बच्चे को दिखाना है in high risk clinic. So with that, I think we will really like to thank all my expert, Dr. Basu, for giving us her opinion and sharing her experience and giving very wise suggestions to us. And all the panelists, you have done an excellent job. And thank you very much. We really learned with you. Dr. Sadhna, of course, is the best, and she has given us so much of guidance. So I think we have exceeded the time, and I would, ma'am, pata nahi kahan chali gayi hai, Dr. Sadhna, I can't see her. So I thank you all on behalf of both of us. Thank you.
Thank you.
Thank
Thank
you
you
very
so
much.
much.
Thank you, Dr.
Thank you
Picky.
so
We
much.
really
Thank
enjoyed
you
and
for the
learned many
wonderful
things.
panel, Picky ma'am and Dr. Sadhna Gupta ma'am, and Dr. Basu's inputs were like comprehensively, they summarized the whole of the panel very beautifully.
Like an experienced person, ma'am.
Yes.
Yes. And those inputs were so much needed. So thank you so much, everyone. All the
Thank you so
panelists
much
were
for these words.
especially very wonderful. Thank you so much, ma'am.
Thank you.
Thank you. Thanks to the moderator.
involving us. Thank you very
Now I
much.
request Dr. Nandini. Dr. Manoj Chelani has been with us since the beginning of the program, and we will end the webinar with his
Most awaited
talk on
session of
DKA.
Dr.
So
Chelani
I
now.
request everybody to stay on, and this is the talk of the day on diabetic ketoacidosis.
Thank you, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am. After a very extensive panel discussion, we move forward to our second talk by Dr. Manoj Chelani, sir, on a medical catastrophe in obstetric as well as non-obstetric patient, that is diabetic ketoacidosis. And to chair the session, I would like to invite our three esteemed chairpersons, Dr. Bhavatarini Madam. Madam is governing council member of RSSDI. She is honorary professor of diabetology. She is also the state coordinator for diabetes post. Madam is national and state award. Madam has received national and state award for academic contribution. She is also the faculty in diabetes training program in DPH Tamil Nadu government. She has been awarded as the best teacher award by the state IMA. She is also the regional coordinator for GDM, faculty in charge for TNGDM national training program, and she is the faculty of esteemed Dr. MGR Medical University. It's an honor to have you, ma'am.
We'll move to the session. Yeah.
Yes, ma'am. Our next chairperson is Dr. Alka Pandey, madam. Madam is professor and head of department of in Lord Buddha Kosi Medical College, Saharsa. She is also the national corresponding editor in Yogi. She has held various executive posts of vice president in Foxy. She has been the ICOG governing council member. She has been organizing chairperson of the Foxy and the VP Vice President Conference in NeighborCon 2023, and she has also held the post of President Patna of Chinese Society. We welcome you, ma'am. Our next chairperson is Dr. Shabana Sultan, madam. Madam is professor and head of department of Gandhi Medical College, Bhopal. She is currently the vice president of Bhopal Oscar Society, and she has been a very active secretary of Bhopal Oscar Society. And Madam has presented many papers in national conferences and published various papers in national.
Thank you so much. Thank you.
Thank you, ma'am. We welcome you, ma'am. It's an honor to have you all. I request my chairpersons to kindly introduce the speaker for today, Dr. Manoj Chelani, sir.
Thank you. Thank you, Picky and the entire organizing team. We are already late. I don't want to delay further. We all know that decay in pregnancy is an obstetrical emergency.
Ma'am, mute.
Ma'am, you have got muted.
Ma'am,
Dr. Bhavtani.
Sorry, very sorry. Thank you, Picky and the entire organizing team. We are already late. And we know that decay in pregnancy is an obstetrical emergency associated with increased both maternal and fetal mortality risk if not promptly identified and treated. For this, we have our wonderful speaker, Dr. Manoj Chelani, who is an obstetrician and gynecologist, the IV specialist, laparoscopic and hysteroscopic surgeon, and he is the director, Ayush Women's Hospital and Test Tube Baby Center, and he is the chairperson Medical Disorders and Pregnancy Committee 22-25, and he is the chairperson Urogynecology Committee IMS 22-24, and he is the chairperson Chhattisgarh ISAR 23-25, and he is again the chairperson Chhattisgarh IAGE, and he is the vice president IMA Chhattisgarh from 22-23, and secretary SAUCI Chhattisgarh chapter, and he is the managing committee member ISAR 22-23, and he is the vice president Chhattisgarh ISOPAB. Over to you, sir.
Thank you. Thank you so much, ma'am. And both that talk was really wonderful, and I really enjoyed panel. So congratulations to Dr. Picky ma'am and Dr.
Sorry, Dr. Chilani, for overshooting the time. Very
No,
sorry.
no issue. And hearty congratulations to Dr. Sadhana Gupta ma'am, and regards to Dr. Seshaiah and all of his peers of this thing, Dipsy and Dr. S.N. Vasu ma'am. And being a chairperson of MDIP committee Foxy, it gives you a privilege to meet colleagues like Dr. Picky and Dr. Monica, who have positive vibes and positive energy and are really a beautiful soul. So I really feel fortunate to meet them and interact with them. And thanks to Infertility and Reproductive and Endocrinology Committee of AOJD and Bhopal Obgyn Society. And all my regards to Dr. Bhaltharni, Dr. Alka Pandey, and Dr. Shabana Sultan. So without wasting my time, let's move on to the topic. Can you see my slides?
No,
Hello?
the slides are not visible, Dr. Manoj.
Are they visible now?
Yes.
Okay.
Will you make it
Pardon?
slideshow कर लीजिए इसको ना?
Yeah, it's in slideshow only.
Yes, yes, now.
Yeah, so we had this patient who was 32 years old, Gradathi Para 2 in her 28 weeks of gestation, and she presented with a 2 weeks history of general fatigue and increased thirst. And she had not been diagnosed with abnormal glucose tolerance before pregnancy, and she had no family history of diabetes mellitus, and she had received antenatal care in a private clinic. Her random plasma glucose level at 8 weeks of gestation, but 75 gram OGT at 11 weeks showed normal glucose tolerance, and she was referred at 28 weeks because of severe general fatigue. So at admission, she was alert, conscious, there was Kussmaul breathing, pulse was 106, BP was 100/60, temperature 98, tongue was dry with sunken eyeballs, abdomen was tender all over and was soft, uterus 28 weeks, relaxed, and FHS was 158 per minute. So certain investigations were sent and which showed that glucose was 348 milligram and HbA1c was 13.6%. So all other investigations were sent like blood gas, which shows pH of 7.4, and urine shows protein 1 plus, glucose 3 plus, and acetone 3 plus. And other tests, antibody tests were also sent. So the immediate point of care glucose test was sent and point of care BHOB was sent. And also lab tests like blood glucose, electrolytes, blood urea nitrogen, creatinine, venous pH and carbon dioxide, and calcium, phosphorus, and magnesium was sent. And serum BHOB, blood lactate levels, and other tests were sent. So what was defining was like when we see all these tests, how to interpret these tests, and which tests are very, very important. Like defining feature of venous pH, if it's less than 7, it's severe. 7.1 to less than 7.2 is moderate, and mild is 7.2 to less than 7.3. And serum bicarbonate less than 5 will tell us about the severity of the condition, and 10 to less than 15 will tell us about the mild condition. And in DKA, it requires a close monitoring of laboratory data. Like every hour, blood and glucose should be monitored. Every 2 hours, BHOB and electrolytes should be monitored. And every 4 hours, venous blood gas and magnesium, calcium, and phosphorus levels should be monitored. So these are the certain tests which tell us the when it should be monitored, at what intervals these tests should be monitored. So diagnosis, DK in pregnancy. So thing is diabetic ketoacidosis in pregnancy. Why it is important? Why today we are discussing about diabetic ketoacidosis in pregnancy? First of all, it is a medical emergency and it is associated with fetal loss of almost 30 to 50%, and maternal mortality is of 1 to 5%. And most importantly, what I feel is these patients land up in casualty ward, and the doctors there or nurses there, they are unable to diagnose this condition. And suppose they first of all they see the blood sugar levels and it's high, they immediately start insulin, which is absolutely wrong. They should start with the fluids. So that is the main problem in this. So identifying diabetic ketoacidosis is very, very important. Proper detailed history of the patient is important. Proper examination of the patient is very, very important. So incidence of diabetes in pregnancy is increasing alarmingly, and we are likely to see more DK in pregnancy. So DK in pregnancy is very different because it is diagnostic challenging. DK present with much lower, at times it may present with much lower blood glucose levels, even normal glycemia, and it is recurrent pregnant women than in non-pregnant women. So diabetogenic state of pregnancy, we see that there's a decrease in counter-regulatory hormones like growth hormone, prolactin, cortisol, glucagon, and catecholamines, and there's an increase in insulin levels. So there's a decrease in effective insulin, there's a counter-regulatory increase in counter-regulatory hormones, and in liver there's increased glucose production, increased gluconeogenesis, increased glycogenolysis, and there's an increased ketogenesis. And in muscles, we see there's a decrease in glucose utilization, and in adipose, there's increased lipolysis. So this all leads to hyperglycemia, and there's a glucosuria and osmotic diuresis, and there's a metabolic acidosis, emesis, and decreased intake. So why does pregnancy predispose a women to a DK? Because respiratory alkalosis will lead to drop in bicarbonate levels, which will lead to impaired buffering capacity, leading to ketoacidosis. And then, if there's an increased lipolysis, it may lead to increased fatty acids and leading to ketoacidosis. Another reason is there's an increased cortisol levels, which leads to increased insulin resistance. That also leads to this ketoacidosis. So there's a triad of hyperglycemia, acidosis, and ketosis. So there are certain investigations which tell us about the hyperglycemia, metabolic acidosis, and ketosis. So we see blood glucose, which is more than 200 milligram per deciliter. Venous pH is less than 7.3, and ketone in blood is more than 3 millimole per liter, and beta hydroxybutyrate or urine ketones, which is moderate or large. So what are the precipitating factors of DK, which was like Dr. Picky was talking about? Patient, she may have a severe vomiting, or there's hyperemesis gravidarum. There are certain infections which predispose to DK, like UTI or other infections. Then insulin non-compliance is very, very important. Sometimes the patient fails to take the insulin, or insulin pump failure may be there. So it's very important we take a proper history, whether she has taken proper insulin, when was the last dose she has taken, and is she on other medications like beta-mimetics and steroids and other conditions, maybe they're like gastroparesis. So these things are very, very important. Patient may come as in a comatose condition, so it's very important you talk to relatives in a very detailed history from the relatives, see the previous papers and all, and that is very, very important. So there are 3 P's like polyuria, polyphagia, and polydipsia. Polyuria is due to glucose-induced osmotic diuresis. Polyphagia is due to inability of the body to utilize glucose, and polydipsia is due to increased urinary water loss. So what are the clinical features of DK? When I said one should be very aware of DK, one should be able to suspect that this patient is of DK. As I said, these kind of patients first land up in casualty. So the casualty doctor or the nurses there should be well trained to identify the DK cases. She may have a history of nausea or vomiting. She may have polydipsia or polyuria, weakness, weight loss, or abdominal pain. And we know there's a typical fruity breath is there. She may have dry mucous membrane, tachycardia, hypertension, and there may be altered mental status changes may be there, and she may come in a comatose patient. So these are certain things which we should be aware to diagnose what we call DK. As other investigation which can point out towards decays, lab findings, like hyperglycemia when the blood sugar is more than 300 milligram per deciliter, pH acidosis is less than 7.3, serum bicarbonate less than 15 milliequivalent, serum acetones are positive. There's an ion gap of more than 12 milliequivalent per liter and osmolarity of more than 280 milliosmol per kg. So lab findings plus the clinical findings will give us the fair idea of the diagnosis of decay. So once you have diagnosed decay, as I said earlier, first and foremost important is fluid replacement before going for insulin therapy or potassium replacement. So this is very, very when we see the blood sugar, blood glucose level are higher, our first reaction is to decrease the blood glucose level or take care of the blood glucose, blood sugar. That is should not be done. It's very, very important that one should do the fluid replacement first. So how it should be done? 0.9% of normal saline 10 to 15 ml per kg per hour in the first hour, and then adjust rate according to the hemodynamic status. When the blood glucose falls below 250 milligram per deciliter, then you add 10% dextrose, 125 per ml per hour on the ongoing normal saline. So this is very, very important. You just keep on monitoring what you call it, blood sugar level, and if it's low, then you can add this thing. Now, what is the role of insulin therapy and potassium therapy in these cases? How much insulin you should give, and is there a need of potassium replacement? When you should replace the potassium? So let's see this. So when the potassium is less than 3.3, you will give potassium and delay the insulin. When the potassium is between 3.3 to 5.5, you will give potassium and will also give insulin. But if the potassium is more than 5.5, there's no need to give potassium, but you should give insulin. So these are certain things you should always remember. How insulin should be given. Insulin should be given in bolus of 0.1 unit per kg and insulin infusion in 0.1 unit per kg per hour. The serum glucose level should ideally drop approximately 50 to 75 milligram per deciliter per hour. So you should do continuous monitoring of glucose level, and this should be the ideal way that you get the drop of glucose level. So for a 70 kg woman, she needs 7 units per hour. So at 50 units insulin in 500 ml of normal saline. So that will be 70 ml per hour, which will be equivalent to 7 units per hour. That is the way you will make the insulin drip and the rate in which you will get the insulin drip. So you double the dose infusion rate and decrease infusion to 2 as serum glucose drops to 250 gram per deciliter. And continue infusion. Am I audible? Hello?
Yes, sir. Yes, sir.
Okay.
You are audible, Dr. Manoj.
Yeah, so continue infusion 12 to 24 hours after resolution of ketosis. Now comes to potassium replacement. 20 milliequivalent, that is 1 ampule of 10 ml KCl to each liter of replacement fluid should be done. Maintain potassium in the range of 4 to 5 milliequivalent per liter. Now we should identify what is the cause which has led to decay and what is the treatment of the cause. As I said earlier, vomiting may be the cause, infections such as UTI, respiratory tract infection or pancreatitis. We have to take the medication history like corticosteroids, symptomatic agents or antipsychotic drugs. She may be on some antipsychotic drugs, or she can be a cocaine abuser, which nowadays is becoming common in certain parts of the country, certain socioeconomic areas. So that we should focus on these and we should treat the cause. Now let's come to the fetus. How the fetal monitoring should be done. There are certain perinatal complications in the fetus in decay. Fetal mortality, as we know, is about 10 to 36% due to preterm delivery, hypoxia, and acidosis. So these are 3 conditions we should take care of, and dependent on severity of the metal condition at the time of presentation. and adequacy of management, gestation age, and condition of the fetus prior to onset of the DKA. So what's the mechanism of fetal loss? Why there's a fetal loss? What happens and why we lose the fetus? So there's massive osmotic diuresis, which leads to dehydration, leading to reduced uteroplacental blood flow. We know that there's maternal acidemia, which leads to reduced placental blood flow. Then there's maternal hyperglycemia, leading to fetal hyperinsulinemia, which leads to increased fetal oxygen requirements. There's an increased affinity of maternal hemoglobin for oxygen due to decrease 2-3 DPG levels, which leads to decreased oxygen to the fetus. There's a gestation age more than 28 weeks. Then we have to continuously doing electronic fetal monitoring until the mother is stabilized, and the FHI abnormalities commonly seen during an acute DK episodes are minimal or absent variability, absent accelerations, repeated variable or late decelerations, and FHR abnormalities disappear once maternal condition is stabilized, and this may take 4 to 8 hours. So it may take some 4 to 8 hours, but finally the abnormalities will subside. And delivery of a compromised fetus should be undertaken only after the mother is metabolically stable. So it's very, very important to stabilize the mother metabolically, then you plan for the what we call delivery. So what are the complications in case of DK? There are maternal complications and fetal complications. Maternal there's a cerebral edema because of aggressive correction of hyperglycemia and electrolyte imbalance. So we should be very judicious in our treatment. There may be pulmonary edema because of aggressive fluid restriction, and she may have shock or vascular thrombosis. Fetus, there may be long-term development problems, brain injury, cerebral edema, and distress. Sorry. So course, what should be the course? What was the course and outcome? In our case, she was treated with IV fluids and insulin infusion, and potassium replacement was done. Fetus showed decreased baseline variability, which got corrected. In follow-up, diet and insulin, diet was taken care of, insulin was given. In subsequent course of pregnancy up to birth, it was uneventful. There was a spontaneous normal delivery at 38 weeks. Baby was healthy, and the baby's weight was 3 kg. And mother continues to be on insulin. So in summary, DK during pregnancy is a life-threatening condition. DKs may be the first presentation of diabetes. Rapid diagnosis and rapid initiation of multidisciplinary team management reduces problems. CTG changes usually are correctable with maternal treatment, and delivery should be undertaken only after mother is metabolically stable. Monitor sugar when giving steroids and avoid beta mimetics, and delivery by cesarean section only for obstetrics indication. So again, I will say at the end that identify DK is very, very important. Management should be proper, fluid replacement should be done, and then you correct the hyperglycemia. So thank you so much for the patient listening, and it's never too early to prevent DK. Thank you so much.
Thank you, Dr. Manoj. I think it was wonderful. You covered all the points, and the key messages like quick diagnosis and prompt management is the basis of managing diabetic ketoacidosis. So if any questions in the audience can put up in the chat.
I think one thing, sodium bicarbonate also can be
Yes.
yes. And you have explained it very well, Dr. Manoj.
Thank you, ma'am.
So we should try at our best that this condition does not arise. So we have to prevent it at first. And then diagnosing it is also very difficult. Sometimes it starts with pain abdomen, and you might not think of this diabetic ketoacidosis.
Patient education is also very important. We should tell her not to miss insulins and take on proper time. And whenever there's this severe vomiting or lots of fluid or lots of this thing, then she should compensate that.
So I just want to add, when you're changing the fluid, once the blood sugar comes to 250, when you're changing to 5% dextrose, add 8 units of insulin in that time. Or else if you're changing to 10%, it should be 15 units, 16 units of insulin. Then give at a rate, whatever you want. And regarding potassium, at the time of admission, don't see the potassium level. You hydrate well, then see the potassium. With the addition of insulin, the potassium gets into the cells, then only you can the potassium gets revealed whether they have hypokalemia or not. So after hydration, you please see the potassium, then decide.
Thank you, Dr. Manoj, for ending the webinar with a fabulous talk with lots of clinical inputs. And I think this webinar has been all about messages and take-home messages, something which can change our practice not only in the government sector and the private sector as well. And this webinar had the right mix of people from the private sector, from corporate sector, from government sector, from key institutions, from DIPSI, as well as from,
Obstetricians and physicians.
Yes,
all.
ma'am. So it was such a wonderful combo, which will be, I think, very difficult to collect by any webinar series. So I think I'm very fortunate and blessed that I, got this opportunity from Picky ma'am. Bhavtarni ma'am was so sweet. She joined our dry run yesterday. Dr. Shabana is always there in my programs to support me. Juhi's inputs were wonderful.
Thank
Dr.
you.
Anjali Kanhare from Bhopal. So I would like to thank everyone, and especially Seshaya sir, for showering us with knowledge all the way. So I would like to end this session with a deep gratitude to all faculties, and especially a big thanks to
Thank you, Monica ma'am,
Thank you, Monica Di, for giving us this opportunity.
Dr. Manoj, your voice is cracking. एक बार फिर से बोलिए.
for this. Thank you, Monica ma'am and Dr. Picky ma'am for this opportunity. And as you know, we started with Medical Monday and we did a lot of this series on diabetes. So it's really wonderful to be part of this webinar.
It is your team, Dr. Manoj. We are always and
We are
let's
your
all
team.
come together.
Yes, the only thing is I could not give the
Monica.
committee name. I could not give the committee name because Dr.
Yeah.
Sunita madam has given
Yeah,
some.
yeah.
Yeah.
That's okay.
So that's
But
okay.
still, without the name, we can work together. Na? It is always work which counts.
So
So-
Synergy Club is always there to support any topic which whoever feels strongly about a topic can please approach me. We have a great platform in the form of INTA's webinars. And the key player is Dr. Vishal Dave over here, who does all our programs with us. Dr. Vishal, you are silent, but you are a very strong person. I know you you withstand all our whims and fancies and work out the beautiful flyers which you see.
Okay.
The arrangement, not a word here and there. We even check the spelling mistakes. So this is
Thank
all.
you so much, Dr. Vishal. Thanks a lot.
So thank you so much, and this is just the beginning of your weekend now. Enjoy your weekend, and thank you all. Until we connect again, we'll keep talking about diabetes, Picky ma'am.
Yes, and thanks to all
Thank
the
you, ma'am. Thank you, ma'am. Das,
and
ma'am.
to everyone. Thanks to Dr. Monica for carrying out the program so well with your vibrant team. Very active, very nice and up-to-date team. Who were contacting everyone and trying to put everything in order. Much all of
Thank you, Vicky ma'am.
Panel was really wonderful. Panel was really great, and Dr. Basu madam also summarized the panel. And thank you so much.
Very nice.
I
And
got the
great
right
talk, Dr.
person.
Chilani.
Ma'am was saying, "मैं क्या करूँगी expert?" I said, "No, ma'am, you have to come." So thank you, everyone.
Thank you. All of you.
Thank you
Wonderful.
all.
Thank you so
Thank
much.
you.
Dr. Babu.
Thank you. Thank you. Thank
Bye.
you.
Good night. Good night.
Bye, Dr. Sunita. Bye.
Bye, Vicky ma'am.
Bye.
Bye, Monica madam. Bye, all.
Bye.
Support team end the program.